Hello, and allow me to extend a warm welcome to all to the 2023 Health Center Workforce Summit. We're so glad to have you with us. My name is Gerard Jolly. I am the Director of Career Advancement Strategies with the National Association of Community Health Centers. And we're proud to bring you this event in collaboration with our partners at the Moses Weissman Health System and the Association of Clinicians for the Underserved. Two of my colleagues are joining me from the planning team to extend a warm welcome to you as well. So let me turn it over to them to introduce themselves.
Sure. Hi, everyone. Excited for the next 2 days. My name is Amanda Shizzle. I'm Deputy Chief Operating Officer of the Moses Weissman Health System and Project Director and co-PI of our NTAP on clinical workforce development. I'm going to leave it to Margaret Flinter later when she gives an overview, but I am thrilled to be here today. Go ahead, Suzanne.
Hi, everyone. My name is Suzanne Spear. I'm the Senior Director of Workforce Development at the Association of Clinicians for the Underserved, otherwise known as ACU. And I'm here representing our STAR Center, which is our National Training and Technical Assistance Partner Cooperative Agreement through the Bureau of Primary Healthcare. And just excited to be here and learn from everyone. And you'll see more of me from me later. Thanks so much.
Thank you, Amanda and Suzanne. So why are we here today and what are we hoping to accomplish? I'm sure you all know better than most that whenever we ask the question, what are the major challenges that you're facing? The top two issues that come up are funding and workforce. And usually workforce is a function, or funding is a function of the need to continue to support a thriving workforce. What we hope to accomplish today, the goal of this summit is to bring you together, all of you from across the health center sector, to highlight the great work that you're doing in the field, both you and your partners, and hopefully to provide some tips that you can apply to help address some of the workforce needs and challenges that you're facing at the local and regional and state levels. In order to do that, what we hope that you'll be able to do at the end of this summit is to understand and describe how to develop a coaching culture, that culture that ensures equity and inclusion for your workforce that reflects the populations that you serve. That you'll be able to be strengthened in your efforts to nurture and build partnerships and pathways for the professional development of your workforce, and that you will be able to continue to identify, create, and advance those opportunities to promote an environment that supports and sustains workforce wellness for your health center staff. So we're excited to be able to be with you today and look forward to accomplishing those goals and objectives with you. Our next slide, please. This summit would not be possible if it were not for the hard work of so many individuals behind the scenes. And so we want to ask you if you would recognize the individuals who served on our National Advisory Group. They provided guidance and support and encouragement to those of us on the planning team. And this event would not have been possible without them. So as you see these individuals over the course of the next day or two, or in the coming weeks, if there's just even one thing that you like about this summit, we ask you to take a moment to express your appreciation to them. And we have some on the next slide as well. And you can find all of these individuals on page 2 of your program. So we just want to express appreciation for the National Advisory Group. And we also have some other partners that we want to thank. And I'll turn it to, I believe, Amanda to
Yes. As 3 NTAP awardees, we are funded by our federal partners at the Health Resources and Services Administration, and we thank them for their support and our ability to be here today with you all. You'll learn more about our NTAPs a little bit later when you hear from our leaders, but this is supported through that funding, as you see here, and the contents are those of the authors and do not necessarily represent the views of that department, but we thank them for their support and the ability to continue to do this incredible work. And I am excited that we get the space to be able to learn from each other, such as today's events. And thank you to Gerard and to ACU and NAC for your collaboration across that funding.
As Gerard and Amanda both highlighted, there are a lot of folks that went into planning actually the next 2 days rather. And so we just wanted to recognize folks from the planning committee made up of staffers from ACU, Community Health Center Inc. and Moses Weitzman Health System, as well as the National Association of Community Health Centers. So you will see a lot of us in the next couple days, but we just wanted to make sure that we recognize those folks as well. So thank you to everyone that went into the planning of this event.
We're always happy to have senior leaders from our organizations join us for the Workforce Summit and extend greetings on behalf of each of our organizations. Unfortunately, Gina Capper, who's the Senior Vice President for Training and Technical Assistance for NAC, had an unexpected conflict and wasn't able to join us today. So she asked that I express some greetings on her behalf. She states, "I bring greetings and welcome from the senior leadership team of the National Association of Community Health Centers. Specifically, our Senior Vice President for Training and Technical Assistance, Gina Capper, sends her regards and appreciation to all of you who are here today and work daily supporting the delivery of high quality, accessible, culturally and linguistically competent care to our over 30 million health center patients across the country through 1,500 community health center organizations, or 1,400 community health center organizations. Together, our nationwide health center family is stronger than ever before. Our NAC team is pleased to work closely with training partners like the Association of Clinicians for the Underserved and the Moses Weitzman Health System to ensure you are receiving the professional development and learning opportunities you need to be even better and more successful at the work you do. There's been months of planning put into this week's Workforce Summit. Our planning group has consisted of representatives from national training organizations like NAC, from health centers, primary care associations, and health center controlled networks around the country who have specific expertise in health center workforce strategies. And our planning group has also included representatives from HRSA. We are grateful for the time, the energy, and effort they gave over many months to prepare what we hope is an inspiring and practical Workforce Summit agenda that you will enjoy and learn from. This summit is a time for you to invest in you. That means please minimize as many disruptions as possible. Resist the urge to multitask. We know that's a difficult task these days. And soak in the promising practices being shared and fully engaged in the virtual peer-to-peer chat and discussions that will be facilitated. This is your time to invest in yourself. This is your time to connect to your National Health Center family. Thank you for being or supporting our health center heroes. Let's keep up the great work and remember, we are in this together. And now I'll turn it over to my colleague, Amanda, to introduce our senior leader from the Moses Weitzman Health System.
Unfortunately, we're at our limit, and I'm assuming it's some sort of Zoom issue, which I know the team is working diligent to resolve. Margaret dropped, and so she can't come back in. So I'm actually going to ask that we have her do an introduction later. I think it's important that we hear from her, and I hope that we can resolve the issue. So anyone amendable to it, once we have more direction, I think it'll be important. But I'll hand it over to Suzanne and Amanda to do their introduction.
Hi, yes, so I am pleased and excited to introduce my boss, the Executive Director of ACU, Amanda Pierce-Kelly. Amanda, take it away.
Thanks so much, Suzanne. I just want to start by giving everyone a round of applause that went in, that contributed to the planning and putting together the incredible program that I know is ahead of us the rest of today and tomorrow. It really is amazing to see the collaboration that comes from across the National Association of Community Health Centers, ACU, and the Moses Weitzman Health System. It's the best of the best, I will say that. And all of you are a part of that as well. And so just really thrilled to see so many of you, and I know we have many others that are eager to join, and so we'll get that squared away. One of the things that we wanted to start with, or that I wanted to start with, was just why are we here, and why is access so important, and what role does workforce play in that, and who is ACU? What does it all mean? I think where I would start is that ACU, the Association of Clinicians for the Underserved, access is core to everything. And workforce is really core to access. You literally cannot have access to care if you don't have workforce. And so everything that we talk about, all of our work really hinges on that. We're very fortunate at ACU to have a bureau grant to support clinical workforce recruitment, retention, wellness, resiliency, all of these things. But I think, at least in my time, having the privilege to work with the Star Center team and with many others in the workforce space, it's bigger than just the clinical space. Healthcare workforce really spans everyone and everything. And to Gerard's point earlier, I don't think, certainly not a week, but sometimes it's not even a day that goes by that I don't talk with a health center who says, workforce is the #1 challenge. And where it used to be just clinical workforce recruitment and retention, now it is every corner. Now it is phone, intake staff, it's call center staff, it's IT, it's operations, it's outreach, it's literally everyone, every part of the equation. And so the work that we do at ACU, and I think I hate to speak for our partners, but I think the work that we all do is to support health centers and all of you to ensure that you have every resource possible to be able to fulfill the work that you're doing, to fulfill that mission, to care for as many people as you can, and to fulfill that mission of access. And so ACU has a 27-year history of this work. And in our 3rd iteration of that bureau grant that I mentioned, but it really does take the team that you see here today. And so just thrilled to have everyone together to learn from each other, and just immense gratitude to all of you who are doing this on the ground, who are serving your health centers, who are serving your primary care associations, who are doing the hard work every single day, and having to wrap your arms around the challenges that exist in the workforce space. So the program today is going to offer amazing programming and solutions, but I think it will also provide an opportunity for conversation and discussion to come up with new ideas and imagine new solutions. So I'm so grateful to be a part of that. I'm very, very proud of our Star Center team. I will just give a little note that the Star Center is going to be pushing out our data profiles coming up pretty soon. And so keep an eye out for that. It can be an enormously helpful resource to each and every health center, and the PCAs have a role to play in that as well. And many new publications coming out, not just from ACU, but I suspect across the board. So in addition to the conversation you'll have today and the programming you'll get the next day or two, incredible resources coming your way soon. So thank you so much, everybody. Bravo and kudos to the team for putting together such a fantastic program, and look forward to the conversation. And I'll turn it back to Gerard, I think.
Thank you very much, Amanda. Is Margaret able to join? Has she been able to log back on?
If she's in the waiting room, if we are able to add her in, hopefully we should be good. And then we'll fix the limit before the keynote. We're working on getting a new link. We're going to email it out in registration. Gerard will tell you when to rejoin. So we apologize for that. We can just keep going.
Yeah, let's have greetings from Margaret, and then we'll give you some instruction. Can we bring Margaret back in?
I think we should keep going through the slides, and then when she joins on, we can pop back over to her.
All right, sounds good. Let's move on to our next aspect on our agenda. Our agenda at a glance, day 1, and I think Suzanne. Oh no, Megan. Actually, Megan is covering this for us. Megan Angers.
Yeah.
Go ahead, Megan.
Yeah. On the agenda for day 1, we have our wonderful HRSA administrators delivering the keynote on the ever-evolving health center workforce landscape, including current challenges, opportunities, and trends in healthcare setting. Following the keynote presentation, we'll hear from the Massachusetts League of Community Health Centers and Massachusetts General Hospital to present on their collaborative HRSA-funded Be Well Together initiative, which is super exciting. And then after that, we'll have some time to connect with all of you, with your peers, on these fantastic presentations and breakout groups. And then following that, we'll conclude our day with a panel on pathways and partnerships, as well as a health center spotlight focusing on integrating justice, equity, diversity, and inclusion principles into their coaching and mentoring culture to foster an inclusive and equitable environment. For day 2, we'll have a keynote presentation from April Lewis on how to manage your time and energy efficiently in the workplace. Following the keynote presentation, we'll have a presentation from Gary Campbell from Johnson Health Center to discuss creating a coaching culture. Similar to the day 1 structure, we'll then go into breakout groups to discuss these presentations, and we'll wrap up our day with a panel on coaching culture and conclude this 2-day workforce summit with a large group discussion. Great, and as for some housekeeping considerations on Zoom etiquette and troubleshooting, for your technology, please check your Wi-Fi. For your microphones, please be courteous and keep yourself on mute, especially if you're not speaking. If you need tech help, you can, we have a designated tech help right now. It's Mariah Blake. Recording, we are recording, so please be respectful of all that you put in the chat box. It will be recorded, and we do have scheduled breaks throughout the summit. So like Gerard said, try to limit your multitasking to be present in this moment, and we do have those breaks built in so you can check your emails and so forth. Additional to housekeeping, we're using the Weitzman education platform, as you are all familiar with. I'll put the link for that in the chat. I know I also sent it out this morning, but that's how you'll be claiming your CEU credits. And I can go through that more so at the end of the day as well. And then finally, our final housekeeping technology consideration is our Mentimeter. We'll be using this throughout the Workforce Summit to launch polls and interact with one another. And our first one is a word cloud on what motivated you to attend the 2023 Workforce Summit. I'm going to go ahead and put that link in the chat, but I already see a few of you joining, which is fantastic. And if you haven't used this before, you can either click on the link in the chat and do it on your computer, or you can scan the QR code with your phone, or you can go to menti.com and enter in the code, which is 25991916. I'll put that in the chat as well. So 3 different ways you can join us.
Megan, I will stop sharing now and pass it over to you.
Thank you. Awesome. And everyone on their screen should be able to see this question. What motivated you to attend the 2023 Workforce Summit? And feel free to enter in a few different words. Thank you all for responding. This looks great.
Gorgeous. All right, well, we're all enjoying this beautiful word cloud. We want to make sure that all of our friends can join us for the keynote. So Megan is quickly working with our team. We have a new link that we believe has a 300-person limit for the meeting. So she's going to email it out to everyone who is registered and replace that old link with the new link so that all of our friends can join us.
Great. So we're gonna take a pause at this particular time, and we'll ask everyone if you would re-log on using the new link, and it's also being emailed out to you. We'll rejoin in, I guess, in about 8 minutes. That's 12:30 Eastern time, which is 9:30 a.m. Pacific time. Thank you for your patience, and thank you for your flexibility as we work through this challenge. I'm sure you've experienced something like this before. So thank you again for your patience and your flexibility. With that, we're going to go ahead and exit at this time, and we'll see you guys in about 7 minutes.
Clear to those who know us well, I hold the same role with the Moses Weitzman Health System, which is the parent company now of both Community Health Center, Inc. and the family of affiliates that CHC developed over the years as we, like so many of you, strove to find innovative solutions to health and healthcare challenges and problems. And in doing so, sometimes those innovations got taken through to the point of being entirely new organizations. I have the great pleasure of serving as the co-principal investigator for the Community Health Center's NTAP on clinical workforce development, along with the amazing, as those of you who've been on them know, the amazing Amanda Shizzle, Megan Angers, and Bianca Flowers, who do a tremendous job. We've had this initiative since 2017, but it's one that's brought us together with so many of you in learning collaboratives and workshops, national webinars, and we've even had the pleasure of speaking at some of your local workshops and conferences. I think Amanda and Megan just got back and went out on the West Coast joining you all. So today, it gives me great pleasure and really is quite thrilling to welcome you to the 2023 Virtual Biennial Workforce Summit, a initiative, as you might imagine, that you can only do biennially because it takes so much to put it together. And we are so excited for the conversations that are going to occur on coaching culture, on workforce wellness, and pathways and partnerships over the next 2 days. I want to thank our incredible colleagues at NAC and ACU for your continued partnership and commitment, dare I say friendship, comradeship, for bringing us together to have these really important conversations. And of course, a big thanks to our colleagues at HRSA that really helped make all of this possible. I started my career in health centers as a National Health Service Corps scholar, like many of you around the country, and a newly minted family nurse practitioner more than 40 years ago. So I've had a front row seat at the ever-evolving workforce landscape and the recurring workforce challenges and some new work challenges that we never anticipated, like the COVID pandemic, throughout the years. I think the conversations that we're going to have over the next 2 days are just crucial. Our long-term success at tackling workforce challenges relies on a collaborative effort across all people. And certainly each of your health centers, I think, is deeply involved in this work. And the health center, along with Moses Weitzman Health System and the Weitzman Institute, is really committed to training the next generation as a foundational pillar of the organization at all levels, across all disciplines, almost 200 students and trainees at any given time. Some of you know us for our work in launching the country's first postgraduate nurse practitioner residency program at CHC in 2007. That was soon followed by a postdoctoral psychology residency program, later by the creation of our National School for Medical Assistants, NEMA, which we partner with so many health centers around the country for. And we are so far from alone in training the next generation. We are really part of a movement with all of you. I'm eagerly awaiting the 2022 UDS data to be published, but if you look at the 2021 UDS data, 82% of health centers were providing hands-on clinical experiences. 20% of the programs they were engaged in were directly sponsored by the FQHC. 15,000 clinical staff were engaged as preceptors, And this training is across the board. It's everybody on the team. It's our primary care providers, it's our behavioral health providers, our dental providers, some of the newer perhaps members of the team, the chiropractors, also our ophthalmology and optometry fellows. All of these are so important to our workforce training efforts and our workforce retention efforts. I think collectively the health center movement is doing a phenomenal job in this area of clinical workforce development for the up and coming workforce, but also in attracting and retaining and reinvigorating today's clinical workforce and health centers. We've had the opportunity through the Weizmann Institute to do some pretty extensive research, training, and publications with the goal of continuing to inspire primary care innovation. And I know you're going to hear about innovation from many speakers over the next 2 days. I'm excited that you're going to hear from our Chief Nursing Officer, Dr. Mary Blankson, speaking about her experience in coaching and mentoring her staff on their leadership journey, as well as the program director of the Nurse Practitioner Residency Program, Charisse Corsino, who also is a regular guest on the NTAP webinars and learning collaboratives. We'll be sharing expertise on pathways and partnership in this work. So thank you for taking the time to join us over the next 2 days. Thanks for being a capacity crowd. We look forward to our continued work with you as we head into the future. And as always, thanks for being here and onwards. Back to you, Amanda.
Thank you so much, Margaret. And I know we'll be transitioning Gerard over to our keynote today.
Yes, I want to make sure that we have our keynote panelists on. If we can identify them and highlight them, if we will. I am happy to introduce Tu Quach, who is the president of Asian Health Services in California and a member of the National Advisory Group for the Workforce Summit. Tu will be moderating this session of our what we call the Big Three of our HRSA Associate Administrators. So without further ado, I'll turn it over to Tu.
Thanks so much, Gerard. I just want to make sure that we have our keynote speakers on. I know that there are some difficulties. Do we know if they're on, Gerard? Just want to make sure.
Yes, they are.
Oh, great. Okay.
I see all four of you.
Wonderful, wonderful. Well,
Yep.
hello and welcome, everyone. I'm so glad that you're able to join across the country and that you were able to hop back on. It is really nice. And I always think we're from health centers, so we always know how to pivot. Again, my name is Tu Quach, and I proudly work at Asian Health Services. We're a federally qualified health center in Northern California. And I actually started volunteering here when I was just a college student because the patients here remind me of my own family. When my family and I arrived in the US as refugees from Vietnam, we had nothing. We didn't speak any English, relied on Medicaid, food stamps, and other forms of public assistance. So even at the age of 7, I was serving as a child interpreter for my parents as they navigated through the difficult and complex healthcare system. And looking back, I wish they had a health center that could have provided them with culturally and linguistically competent care. That has always been my inspiration for working here for the many years. I am so grateful to the many, many health centers across the country that does the hard work of providing care and addressing social determinants of health for the millions of underserved patients. Yet, while extremely rewarding and fulfilling, the work can really take its toll on our staff. We often talk about centering patients in this work. It's just as important to center our very hardworking and dedicated staff, now more than ever. After 3 years of the relentless pandemic and everything else, it's time we put the focus on the wellness of our frontline heroes, because they truly are heroes. I'm so grateful for this virtual summit, where we can hear from experts from all over, share strategies and lessons learned. And I'm really, really honored to be able to moderate this amazing keynote panel with 3 exceptional panelists who will share their strategies for enhancing wellness in the health center workforce. So I'm going to go and introduce each one of them. And I just want to say their shortened bios do not fully do justice for the many accomplishments and years of service. So first up, we have Jim McCrae, who became an associate administrator for primary health care in the U.S. Department of Health and Human Services, Health Resources and Services Administration, HRSA, in May of 2006. He has led HRSA's Bureau of Primary Health Care for more than 15 years, managing a budget of $5.7 billion that supports nearly 1,400 health centers, which operate approximately 15,000 service delivery sites in every state, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, and the Pacific Basin. Next up, we have Dr. Luis Padilla, who is the Associate Administrator for Health Workforce at HRSA. He also serves as the Director of the National Health Services Corps. Dr. Padilla was appointed Associate Administrator for the Bureau of Health Workforce in May of 2016. Prior to joining the Bureau, Dr. Padilla was Senior Health Policy Advisor to the CEO of Unity Healthcare in Washington, D.C., a federally qualified health center network with over 100,000 patients. He is also a family physician. Last but not least, we have Tom Morris, who serves as the Associate Administrator for the Rural Health Policy in HRSA. In that role, Tom oversees the work of the Federal Office of Rural Health Policy, which is charged with advising the U.S. Department of Health and Human Services Secretary on rural health issues. The office, which has an annual budget of $317 million, administers a range of research and capacity building grant programs that serve rural communities. Welcome to our panelists, and thank you so much for making time for this important topic. So I'm going to jump into the questions, and the first one is going to be towards Jim. So Jim, we know that the Bureau of Primary Health Care conducted the Workforce Wellness Survey the past year. While we know you are still analyzing and finalizing the results, are there any preliminary findings or early returns that you're able to share with us?
Great. Thank you so much, too, for being here and being a part of this panel. Really happy to be with my colleagues also. But a big thank you to all of you out in the health center community. Thank you for making the time today and over the next several hours and days to really focus on a critical issue for us, the health center workforce. I think as many of you, and you probably heard me say, 70 to 75% of the budgets of health centers actually goes into personnel. And it's a reflection of, you know, where your dollars are is where your support needs to be. And we feel like we need to do an even better job of supporting our workforce in the health center program with some of the activities that we're doing. Margaret actually touched upon a real effort that we're trying to do around training and really building our own pipeline. But we also are worried about our current workforce and how are things playing out there. And we knew before COVID that primary care was stressed and our workforce was under an enormous amount of pressure to do more and more for the patients who need their services. And that actually was when we began to think about doing our workforce wellness survey. Then, of course, COVID happened and just put a greater spotlight and greater pressure on our workforce. But we decided to go ahead and do the survey anyway, because we felt like it was important to get a real temperature check of what our workforce was feeling. And there was a little bit of trepidation, I'll be honest, when we engaged with health centers across the country. There was definitely some real concerns about, number one, why are you doing this? Number two, why are you doing it in the middle of COVID? And what are you ultimately going to use this for? And I will just say that the reason why we decided to do this is because we just, again, feel like our workforce is so critically important. And it's so critical to all of us to make sure that we are supporting our staffs in the best way. So we felt like that was critically important. So we did the survey from November of 2022 until January of 2023. We were very excited because we had almost half of the health centers across the country agree to participate. So that was a great number. We were really happy for the first time we've ever done this. The second thing is we received responses from over 50,000 staff across the health center movement. So that was fantastic. We also had 22 health centers that had more than 80% participation of their staff. So that was great. In terms of some of the preliminary results, they actually turned out to be better than we anticipated. We will be sharing the full results later this summer, the national picture, and then breaking it down at the state level. The individual health centers who participated in the survey have already received their survey results back. And I'm very pleased to say that many of the health centers have already started asking the question, when are you going to do this again? This is so helpful. So I think that initial trepidation and concern is starting to go away with the results that we're starting to see. But in terms of those results, I don't think it'll be surprising. Strong mission orientation, that was the highest rated area, not a big surprise at all. The meaningfulness of the work that people do at the health center and in their health center programs was the second highest. Engagement was actually the third highest in terms of what we saw. And then my work team and supervision and leadership and positive workplace culture scored next highest. So we saw some really positive results and really good scores in terms of that piece. Not surprisingly, the areas that scored lower were around the whole issue of burnout. I think a lot of people are really feeling exhausted and really figuring out how to recharge their batteries and support one another better. Workload was another big issue. And again, that's not a surprise. I think if anything, COVID just put a greater emphasis on the need for primary care and what we expect from it, but workload was a big issue. And then I think just the environment that people work in, the sort of disconnect between what people were trying to do in response to the pandemic and some of the political challenges in that space, and just really, I think, feeling more questioned than they ever had before in terms of just what they were trying to do for their patients and their communities. So we got some, I think, really great results. As I said, we plan to do a full rollout later this summer. We will provide information to all of the health centers. They'll be able to see, of course, their individual results, but then comparison reports to see how they compare to other health centers across the country within their state and nationally. We will be providing this information to our primary care associations as well as our national partners. And this data will be up on our website so everybody can see it at a national level. What we hope to be able to do with these resources is, number one, I think be able to provide a better national picture of what is happening with the health center workforce. We are continually asked, especially with reauthorization happening, how is the workforce doing in the health center program? What are the additional needs? Now we're going to have some concrete quantifiable data to be able to talk about that more clearly to policymakers and folks who are making decisions about reauthorization and funding. We also, though, we're going to, of course, use it with our technical assistance partners to identify both areas of strength as well as areas for improvement in terms of how can we better support health centers out there. The last thing that we're hoping to be able to do, of course, is to provide information to individual health centers. And we have a whole variety of things that we're looking at. Everything from developing learning collaboratives so health centers can learn from one another. Of course, doing some technical assistance webinars targeted specifically to the areas that particular health centers are maybe struggling with. We're also looking at doing case studies as well as office hours, but basically an opportunity for folks to learn from one another about what is working and what is a challenge. So really excited about this. Doing this survey was one of those decisions where it's like, do you do it? Do you not do it? And we made the decision that let's do it. And we'll see where we end up. And, not surprisingly, health centers have done an amazing job in spite of all of the challenges that primary care is facing, in spite of all of the challenges with COVID. And I think really is a testament to the work that we all do in the health center program. Doesn't mean that there aren't things that we need to work and support on to make sure that we continue to be the employer of choice beyond just being a mission-oriented organization. But this, I think, will really put us on a path to go forward and do even greater things together. So I'll turn it back to you, too.
Thanks so much, Jim. I know many of us are really interested in the results and we'll be checking it out on the websites and such. I wanted to go next to Dr. Padilla to get some of your thoughts on workforce wellness. Trying to see if Dr. Padilla is on. There he is. Oops, Dr. Padilla, I think, oh, great.
You see me and hear me?
Yes, we can hear you.
Oh, thank you, Thu. And thank you for having me participate in this workforce summit, such an important topic to discuss, and been very fortunate to be included in your discussions in prior ones. So glad that you're full capacity today. So talking about resiliency really is a part of what we're doing right now, and recognizing that the pandemic has really hit our workforce hard across all areas of work, not just in community-based training. But what I want to share is our overall effort to improve and assist the capacity of organizations like FQHCs and others to increase their capacity to do education and training. Obviously, the most recent effort and the ongoing effort with the Health Professions Education and Training Initiative, the partnership with BIPIC, has been quite successful in many regards. And just to recap, we kicked this initiative off in 2020, and I just want to thank Jim again and his team for their leadership in partnering with us on this. But that collaboration, which has led to funding in all 52 states and regional primary care associations of full-time FTE dedicated to workforce, is really one of the more significant accomplishments of this overall effort. Obviously, the RTAT that was developed by CHCI Inc., and I want to again thank Margaret and her team for developing that tool, deploying that tool, and sending out all the reports, more than 1,060 reports nationally to all the health centers that participated. We think that overall this has been very successful. It was the first of its kind to look at where health centers were in terms of their evolution and their path of education and training. And we hadn't seen this data before. And we recognize that it wasn't perfect. It didn't capture everything. And we want to find ways to use additional data sources, including the survey that BIPIC just deployed in conjunction with this RTAT. But the response was overwhelming. Our target originally was 70% or 50%. We achieved more than 70% response rate. Over 1,000 health centers that participated in that and responded really gave us good insight into where health centers were. And just to highlight some of the responses nationally, 40% of those respondents indicated that they were currently sustaining health professionals training programs. That was the first time that we had at least a snapshot of how many of them were conducting health professions training programs. And I think one of the more telling statistics here was that only 1.5% indicated of those who responded that their health center was not engaged in any professional training program. And that to us was really promising. That meant that many health centers, at least the ones that responded here, were already doing some education and training. And that was something to build off of. But obviously have a lot of room to grow. And one of the things that we're focused on now that the readiness tool has been deployed, the data has been provided nationally to health centers and PCAs, is working on that third component of workforce development plans. And that's where our efforts are focused right now. How can we assist health centers in developing those plans? We know that it's an arduous effort to get support to develop those, start to think of the partnerships that you need and how you might be able to use both federal, state, and local funding to support your overall efforts to increase your workforce. But we think that that's the work ahead for us. How can we assist you in establishing those partnerships with academic organizations? How can we further what you are already doing right now in terms of education and training? Many health centers are already taking advantage of our numerous workforce programs to bolster their workforce, both now and in the future. But how do we increase that capacity? And one of the things that we launched last year as a part of this, recognizing that we needed to better inform health centers and PCAs about our programs, is an initiative that we call the Regional Workforce Workshops. We were fortunate that we were able to hit 6 regions last year, starting in the fall of 22 and then going on in spring of 23. We have completed these workshops in regions 1, 2, 4, 5, 6, and 7. We have 4 regional workshops planned in this year, including region 9, regions 3, 8, and 10. So we want to complete that process to at least complete what we saw was an important part of this overall effort, and that is making you more familiar and aware of our programs, how they relate to health centers and other community-based organizations, how we can facilitate partnerships, how we can share the data that we're producing at all levels of our programs. We've gone a long way in externalizing a great deal of our data that we haven't had before. And how do we put that in your hands, make it useful to you, that you can utilize it not only for workforce development efforts, those plans, but also those that are starting and wanting to partner and wanting to if you will, advocate at the state level for funding or take advantage of funding available at the state and local level. We think that this data is really important to get out. But we recognize that there have been some challenges. We've already gotten feedback from PCAs and those who have participated in our workshops, wanting us to continue to work on bidirectional communication, wanting us to recognize that precepting, and while that is an effort underway, and we've put out some funding to support some of that, we're still limited in hearing from all of you that more precepting support, more infrastructure support, the challenges that you're having in not just recruiting, but also retaining staff. You're losing staff to other health systems and organizations that are also challenged with workforce needs. So we're hearing that in addition to, again, your workforce that you currently have and has been with you is feeling not just the pandemic, but even before then, the impact of burnout, wellness. And while we've put out funding in that area, there's still more work to be done. So for us, what's the look ahead is, how do we improve that bidirectional communication that you're asking for? How do we promote the evidence-based strategies, those models, those practices that we have begun sharing during these workshops, these PCA workshops? How do we do more of that? And how do we complete not only the regional workshops that we have, but how do we enhance them, modify them, make adjustments to them just as useful as they can be to all of you that participate? So I think the work ahead for us is promising in that the health centers that have been working with us, not only on the RTAT, the HBET, the workshops, have demonstrated a willingness to engage in health workforce education and training, but we see a potential for broader engagement, not only with community-based organizations, but with academic institutions that also are showing a willingness to partner with community-based organizations, disseminating our best practices, models of education and training that we believe are effective and ready to be expanded. And then also doing more to make sure that community-based organizations in rural and underserved areas are aware and able to come in for funding as best that they can, both either directly or in partnership with academic institutions that we typically fund. Thank you.
Thanks so much, Dr. Padilla. That was really helpful to hear about the different programs and some of the learnings from it. I wanted to go to Tom and see if you had any thoughts on some of the workforce wellness that we're discussing.
Well, first, thanks for having me, and it's great to be a part of this panel. So many of the health centers are in rural areas and serve, really challenging situations. So I can only imagine everything Jim and Louise have already talked about is just even more pronounced for many of the smaller health centers serving to very disparate populations. I think obviously I think they've covered the ground really well. I agree with everything they've said. I think one of the things is what's new and what's emerging. And as I look back and I thought about that, the strategies really haven't changed over the years because I think they still work. The whole notion of growing your own, of getting people, if we take people in health profession programs and expose them to training, the academic literature is pretty solid here. If you expose them to training in rural and underserved, they're much more likely to consider it. That's easy to say, hard to do. If you take on students, that adds to your burden. We get all that. You assume costs when doing that, and you can't recover them. So, it's one of those real challenges in that I think everybody knows what works and how to do it. Challenge, of course, and I saw it pop up in the chat, is how do you fund it, and then more importantly, how do you sustain it? And I wish I had a nice, easy solution for you. I don't, other than you have no real choice other than to keep plugging away and do the best you can on it. I think one of the real dilemmas, and I think it's true for health centers, it's true for a lot of the other provider types we work for, is the ultimate beneficiaries of all of the health profession training programs at HRSA are the health centers, are other clinics and hospitals in rural communities. They're not the ones who tend to apply for the funding because it goes to educational institutions. So, how to Luis's point, I think, how do you create more academic community partnerships? And I sort of believe that they need you more than perhaps you even need them, in the sense that they need to get their students out and rotated to meet their clinical training requirements. But those relationships, sort of have to be nurtured over time. And that is, I think, the real challenge. And how do we sort of nurture those along the way? We do have some small amount of funding in our office through our community-based program to fund activities that could be focused on workforce. Our grant authority is pretty broad. It just says improve access to or coordination of care in rural communities, and health centers have really tapped into this funding. A lot of times though, for like chronic disease management and really important things, but they could use the same funding for workforce partnerships. And it's not permanent funding, but it could be startup funding. And I think the one I would probably think about that would be worth really thinking about is our network planning grants. We do about anywhere from 15 to 25 of these a year, and it's $100,000, and it's just to bring stakeholders together. So I could easily see a partnership where health centers might come together with their AHEC, their PCA, their state office of rural health, some of their educational institutions, and really think about, okay, how do we use this money to get a partnership started? And then what sort of a network could we create that we could then sustain beyond that? Especially when you consider the money you're spending on recruitment and retention. I mean, what does it cost to hire a firm to do that right now to get a doctor, $60,000, $70,000? And there may be other ways to think about that. And maybe our grants could be a jump start towards that. One of the activities we've funded in the past year has been to sort of expand the work of the National Rural Recruitment and Retention Network, or what we call 3RNet. Just about all of the states are members of this. And some of the states are very actively engaged, and I imagine some of you work very closely with your state coordinator, but some of them are more limited in their resources and may just be able to only post jobs. So we really charged the 3RNet folks with sort of thinking more broadly about what they could do. So they now have an annual 3RNet Academy where you can sign up, and kind of like this workshop today, but even more hands-on, focused on strategies. You could sign up and be part of that, to sort of learn from them what the experience that they've had in sort of recruitment and retention over the course of the last 25 years. Because I think at its core, when the states that do this really well, it's community development. It's actively working with those clinicians, not just to get them to come consider working in your health center, but to continually recruit them every day, every week, every month, because it's never ending. And then realizing though that the costs of recruitment are growing each year. The thing that 3RNet is rolling out in probably the next couple of weeks is a new activity called 3RNet Tools. And so these are very affordable sort of resources that people could get and sort of tap into to sort of implement their own recruiting strategies. So I would say stay tuned for that. We'd love your feedback on whether you find it valuable or not, because if you do, great. If you have suggestions on ways to improve, we want to continue to expand what they can offer both at the state level, but also at the individual community level. And the only way we're going to know that is if we hear more from you all. Two other points I guess I just hit is I think, the health centers were sort of the birthing place, I think, in many ways of the community health worker, movement. Certainly with the investments from the American Rescue Plan that Luis had, and we had a smaller amount. I think we've really seen an expansion of this. The sustainability is always a question. I think what Luis did in terms of aligning with the Department of Labor around traineeships really made a lot of sense and may help towards that sustainability. With our funding, what we thought about trying out was sort of cross-training community health workers, not just to do their normal sort of, coaching people through the healthcare, kind of like what you talked about with your parents. But then also, could you cross-train them in coding and billing and sort of other navigation activities so that they could show more direct value? Could they do benefits counseling? Because if they don't show direct financial benefit to that CEO, it's very hard to keep paying that salary. I am encouraged that we're seeing more health centers and community health worker activities being able to negotiate directly with Medicaid managed care organizations to fund community health worker activities. I think probably what we lack now is sort of a database or a compendium of showing who did it well, how did you do it, and do you have any ideas on how I could leverage what you've done? I know we've worked closely with a foundation in West Virginia that's been very successful at sort of getting managed care organizations to sort of contribute towards this. And if anybody's interested in learning more about that, please drop me an email. I guess the last point I'd touch on is I do think there's a tremendous opportunity in the behavioral health space this year because of the changes Medicare made in terms of for this year with general supervision for family counselors and professional counselors and family therapists. And then next year, they'll be able to bill directly. Unfortunately, for whatever reason, CMS in its rulemaking didn't allow to extend that general supervision to health centers or rural health clinics. So this year, we're not able to fully leverage that. but starting next year, you will be able to bill directly for that. And then the hope is that for other professions that can do the general supervision, like peer recovery, addiction specialists, those sorts of providers, those are a little easier to recruit to underserved and rural communities. And maybe they can help plug some of these gaps we see in the behavioral health space, given the paucity of psychiatrists and psychologists and even licensed clinical social workers. So the rulemaking is going to be coming out on that pretty soon from CMS. So I think the other thing is just really paying attention to it and making sure it works in the context of community health centers. Those are a few thoughts for what it's worth.
Oh, it's worth quite a lot. Thanks so much, Tom. You cover so much. I just want to go back to Jim and, this concept of growing our own. That's so critical as we think about the communities in which we serve. What would you say to our health center board members and even leadership about the return on investment when we think about growing our own?
Well, it's interesting. I think most of you know we are facing a mandatory funding cliff in the health center program. Folks are aware of that, I'm assuming. So we've had the opportunity to engage with the folks on the Hill, both on the House and the Senate side, and they've talked a lot to us about workforce and, how do we develop the workforce. Luis has been an instrumental partner. Tom's been a great supporter in terms of what we're doing with FQHCs. But they have asked, what can health centers do in this space? And I said, initially, my experience, when this is, more than 10 years ago, I think most people, when they thought about workforce in the health center program, they immediately gravitated to the National Service Corps, because that was a way to get clinicians in, especially through the loan repayment program, to address immediate needs. What I have shared with people on the Hill, and I'll share it with you all, is that what I've really seen in the last 5 years, especially with the introduction of the Teaching Health Center program, but also our nurse practitioner programs, other programs that health centers are working on, there is so much more of an emphasis in the health center community around training, and that we need to be a part of it. Otherwise, it's not going to happen. And while the National Service Corps is still essential, that's just putting a Band-Aid on the situation. We ultimately have to be part of training the future workforce. Otherwise, we're not going to have it. And what I have seen, and I've seen it from board members, I've seen it from CEOs, CMOs, the staff, if we don't do the training ourselves, it's not going to happen, and people aren't going to come to the health center program. So yes, it is not inexpensive. It does take time and resources away. On the other hand, it is one of the key solutions if we're actually going to have the workforce that we want for the 21st century, if we want people to go into primary care, if we want them to go into underserved communities, if we want to make sure that we have staff that coming out of training actually can do what we need in the health center program. So I have seen a remarkable pivot, and I'm really excited about it. We are trying to support that with, of course, the new elements we've added to our UDS around training. It really shows the breadth and depth of what health centers are doing. But we're also looking at ways from the service delivery side. How can we support it? So we have created opportunities in our grant announcements to say, if you need, when we have construction dollars, space to support expanded training rooms and places for students to be able to get, classroom kind of didactic training, let's do that. If we can, create opportunities working with Luis around supporting not just the academic side, but the service delivery side, we're trying to look at that. So I would just say, if you haven't made the leap yet, and I would say at this point, most health centers have, this is absolutely essential. And you are building it, not just for yourselves, but for the greater movement. So.
Thanks so much, Jim. And Dr. Padilla, I wanted to ask you the same question. What would you say to our boards and leadership about growing our own and the return on investments?
Well, I think it's absolutely critical. And I think many of you have heard me speak on this before. My charge to all of you is it needs to be part of your ongoing mission. The health center movement, for certainly the years that I've been involved in before, have been, and rightly so, focused on healthcare delivery to the underserved. And I think that that's a mission that needs to continue. But the flip side of that mission is the workforce. And I think we're seeing that now play itself out. I don't think that continue to operate with having workforce be a second thought. Whether it's on value-based purchasing, because that discussion is going to come back, or anything else, we have to continue to say you can't do health service delivery without looking at workforce. It's on the same. So I think if anything else, every day I hear how someone is interested in workforce, and I think that's great. But you have to really intentionally look at what's happening right now and say, okay, more than just saying it's important, what are we going to do to make sure that some of the paradigms of health workforce education and training change? Because what we're dealing with here are paradigms that are decades long, whether it's on admissions, matriculation, where people go to graduate, and it's changing bit by bit. So it's not just on the health center side, but also on this traditionally based academic environment. And we're trying our best to say, has to be a new world. And I think if anything positive has come out of the pandemic is, sadly, they're feeling the workforce crunch now more than ever. I think health centers have always felt that because it's been a mission-driven movement relying on those who want to do that kind of work. And other organizations have been a bit immune. Now they're not immune to that, whether it's hospitals, academic institutions, everyone has really felt the pinch. And now let's not lose the opportunity that this dialogue has come up about workforce. What does that mean in terms of these paradigms? So I think that health centers are on the right path right now. What we've seen, according to, when we're looking at our data, more FQHCs and community-based organizations are coming in for our clinic. Even the most recent one on our substance use treatment and prevention, where we got some expanded authority to support provisional licensing. I know of health centers who came in for that funding. So that wouldn't have happened before if we weren't being more intentional about the funding that's available, being more intentional with taking the opportunities to engage with those staff about the importance of community-based training. This is a paradigm shift. While we say, oh, the recipe is the same, it hasn't happened in mass. And I think more and more now, both sides are recognizing the importance. As Tom said, they may need us more than you need them, and us by meaning those community-based organizations, but it hasn't hit home to them the importance. We need to continue to say there's a value proposition on both sides. Because I don't think we're going to set up a situation where one wins and the other one loses. We have to sort of set that scenario to say it's in your best interest to shift in this direction.
Thank you, Dr. Padilla. I wanted to go back to Tom to see if you had any thoughts, especially when it comes to the rural health centers.
Gosh, beyond what I said, I'm not sure I have anything, other than that, other than an acknowledgement of the fact that even more so than all the health centers, they're wearing multiple hats, but I think it's even more pronounced in rural. And the burnout factor, I think, can get a little bit higher there because you may have, especially at some of the smaller access points, a single clinician, whether it's a physician, nurse practitioner, or PA, and that's a really tough dynamic over time. So, encouraged to see the resiliency funding that the Congress provided to BHW to do that. But I think the rural urban dynamic is probably less impactful here than the overall issues I think that Jim and Luis laid out. I suspect that health centers feel the same way about all these issues that they've raised. It may just be a little bit harder in rural.
Great, thank you. So now we're going to take some questions from the audience, and I know that there are a few. I think the first one is directed at Jim about whether the PCAs could get the information. This is referring to the workforce wellness survey before it goes out live on the website or it gets released to the media, just so they have a little bit of lead time to prepare.
We will figure that out. So we will make sure that it is available. So yes, we will do that. Great.
And I'm just looking at the questions that we have. There were a number of them. I know that, sorry, I'm just scanning through. There's a lot of comments about this. And there was also a question about whether folks who are interested in being part of the region that Dr. Padilla talked about could also be joining on that. And I know that folks are also putting their names on that piece. And then there was a question, Dr. Padilla, for where they can find dates for the regional workshop and be involved in planning for the region as well.
Yeah, so we will, and we've already started collecting some emails here to make sure that those that are in those regions have that invite when it comes out. We typically will announce that about 3 weeks before, 3 to 4 weeks before we launch them. And what we have done since we started the workshops is incorporating a period of input from the regions that are going to participate. So it's not just us setting the agenda. We really want to make sure that the partners that need to be on those workshops are on. We've added our rural partners. We've added workforce boards, state boards to those invites as well. So we really want the participants to drive the agenda, what they want to hear about, the programs that we want highlighted, because from the outset, we realized that these need to be tailored to the region and even perhaps the states within those regions. Some regions said, hey, for us, nursing is really what we want to hear about. Others said oral health is what we want to hear. So we're not really taking the approach of one size fits all, right? What is it that specifically in your region you want to hear about? And we'll include that. And we're really highlighting what's happening within those regions and states that we're supporting to highlight those best practices and models that other participants and states might be able to take advantage of. If you don't mind, I saw one of the questions here that I thought was really a good question. And that is, what does it mean to build your own paradigms? They said examples would be encouraged. Okay, this is important because building your own can have different connotations. And health centers have started on the path of two different versions of build your own. One is we're going to go after a program and get accreditation. So CHC Ewing, and not Inc., but I think a Community Health Center University got accreditation for PAs and social workers. I think it was for PAs most recently. That is one form of building your own, where you're going through the accreditation process and starting your own school. And that's what they did. But what that does is it puts you in the traditional model of accreditation, right? You're getting accredited in the usual way that programs get accredited. It doesn't take into account necessarily what you want as a future workforce. So that's one model of, quote, build your own. The other is to starting completely new and say, we want to develop a workforce that is reflective of our needs, students and trainees that have the characteristics that we want, that will ultimately go into these organizations. That's a very different model than going after a traditional accreditation. So thank you for that, because building your own can take on different connotations, and it's a different lift depending on the way that you go. And in terms of paradigms, I would say the most glaring one is actually two within our portfolio, THCGME. That is a paradigm shift from the way graduate medical education is funded in this country. The CMS model funds hospitals to train residents. The THCGME model funds community-based programs to train residents. That's very, very different. So that's just one start. The other one is the nurse practitioner residency program that we support. One is very traditional and academic, and the ones that we really want to support, we support both, are the ones that are community-based. That too is a paradigm shift. That did not occur before our funding. I mean, it was occurring, but the federal government space now in that is another paradigm shift, if you will. Sorry for that long-winded response there.
No, that was perfect to bring it all together. I wanted to go to Tom. You talked about behavioral health and the changes in having the LMFT. There was a question about how can we get LPCCs to have supervised hours so that they can get their license, and are FQHCs able to bill for that?
That's the licensed professional counselors.
Mm-hmm.
Yeah, I mean, like, so the big change for 2023 was moving them from where, you had to have direct supervision, which is, cumbersome, to general. So that authority exists for this year, and then starting next year, it becomes moot because they can bill directly. So, I think we're sort of in a holding pattern for this year, especially since they didn't really extend it to the FQHC setting. I think, though, so that will solve itself just because in the omnibus they gave direct billing. I think the larger challenge, I think, both for community health centers, but also other community-based mental health providers, is this other range of professionals that's going to fall into that general supervision category, because it will enable you to put people off site. Like, they won't have to be on site where their supervising clinician is. General, it's a much more flexible model. So especially as I think about health centers with multiple access points, you could have one at a hub, and they could be supervising 5, 6, 7, peer recovery support or addiction specialists out in there. And so I think the challenge is getting CMS to, and they have the authority, I think, to extend it to RHCs and FQHCs so they can do the same thing that any sort of physician fee schedule provider could do as well, but under the unified payment of the FQHC.
Yeah, no, that's great because there's such a need for mental health and behavioral health services. So this is really critical. Dr. Padilla, there's another question for you. The funding you addressed, what would be your recommendations, i.e. program development? I think you mentioned some of the funding.
Yeah, I saw that question. I wasn't sure. I need a little bit more context, but what I mean by program development. I would say if you're not already started on education and training, to get started. I think many health centers and community-based organizations are already on that path, but they may be doing it ad hoc. I think if you're part of the regions, those regions that I mentioned in those workshops, participate. Come in here about what funding we currently have available, what's coming up next, how they operate, because you hear from our subject matter experts on how they work, because not all of them are directly available to health centers. That's the first thing. Not all of our programming health centers are directly eligible as primary recipients. They, unfortunately, many of them, they need to partner. But more and more, I think there's being appropriated programs that allow health centers to come in. For example, our nursing programs. All of those really require partnerships. Even our nurse practitioner residency programs require partnerships with academic health centers or academic centers and hospitals to survive. Even the teaching health center GME program requires willing hospitals to be venues for residents to train in addition to their outpatient community-based training. So I think we have such an array of programs that it's important to just become familiar. And I think that's the first best starting point. But if you're not already doing it, look into it. We have TA webinars when things are released. We're doing more and more pre-release as best we can to signal to the field that funding opportunities are becoming available soon.
Great, thank you. And Jim, you have your hand raised.
I have my hand raised because I actually wanted to ask Louise a question. I never get this opportunity in front of the entire crowd, so I figured I might as well do it. So Louise, we've talked a lot over the years about just the developing the interest in the teaching health center program. Can you, I don't know whether you can, but can you share just a sense about how many applications you have gotten in, both on the sort of planning side and then the application side? Because I think we've seen pretty significant growth.
Yeah. So before ARP, we had limited amount of funding to put out new competitions, and there was a period of time before the ARP where we didn't have a competition at all. I think 2014 was the first time we had a competition before the ARP funding. So the 330 that we got in ARP allowed us the opportunity to expand the program. So we put out in total, I think it was 4 different competitions to expand, create new ones, and then to support the planning and development of new accredited residency programs. What we saw in the expansion GME, the regular GME program, was at times not enough applicants to meet some of our estimates of applicants that we would get. We were able to expend the money, but we thought we'd get more applicants. And I think part of that has historically been the sustainability of the funding. If you're going over a funding cliff every 2 years and the residency program takes 3 years, it makes you a little nervous about investing and starting a program. So we're encouraged that some of the activity on Hill has a much longer period of extension for this program beyond 2 years. The planning and development, what we saw was we had more than enough applicants to expend the money that we had. So we brought online, and we'll be bringing online 93 planning and development awardees, all of which are FQHCs, every single one. Including, and actually some of whom are rural health clinics as well, which we're very happy about. So all of those are on the path to develop residency programs. And in this next rounding of award, I think there's going to be some of those that we gave planning and development last year that are going to come in for our GME funding. That shows us that they were already moving towards not only establishing those programs, but getting ready for that funding. So we're encouraged. I think the issue really is, are we going to have enough funds from Congress to support all of that growth? Because I think that planning and development, and we have a technical assistance center from UNC that's supporting all of those planning and development awardees, is encouraged by what came in, but also it's a daunting task to establish these residency programs. And so we hope that Congress at the end of the day really is going to act to help support all of the growth that we've established so far. Does that help, Jim? I miss anything? Right.
Thanks so much. I know Tom has his hand raised, and I also want to point it out that Tom put in a link. I don't know if you also want to mention about the link as well, Tom.
Sure. I put in a link for the network planning program, just so folks could get a sense of what the application looks like. We release the notice of funding opportunity each fall, review in the winter, award in the summer. So it's something you could, it's probably our most accessible funding opportunity, and it requires multiple entities to come in together. But I wanted to follow up on Luis's thing. I should have mentioned this in my opening comments because we share a TA center because we also operate a GME program, the Rural Residency Planning and Development Grants. And what we've been able to do is get people through the accreditation process and then flip them either to Medicare or Medicaid in perpetuity. So often rural hospitals are the applicants, but they don't have to be. It could be a not-for-profit. There's a lot of ways to do this. I still think teaching health centers is probably the better model for health centers because it's tricky with the Medicare GME funding flows. You have to who bears all the costs, those sort of things. But having said that, particularly if your state is an aggressive state in terms of supporting Medicaid GME, it might be worth, if you have good relations with your rural hospital nearby, thinking about them because, you're a natural place for them to get some of those primary care rotations, and some of the more hospital-based rotations could take place in a rural hospital. Some of them will have to go upstream to a larger tertiary. But we've had this grant for a number of years, and what we found is that we've been able to create several hundred accredited rural residency slots that are now funded in perpetuity by Medicare or Medicaid. So depending on the situation, teaching health center, traditional Medicare, Medicaid GME, the rural GME folks, that's the name of the website that we share the TA center on. What I think they're really good at is sitting down with you and sitting in there and saying, well, if you want to go THC, here are the things you need to think about. If you wanted to look at perhaps the more traditional residency model, here's how the RRPD works. So, just Google rural GME. Even for your urban health centers, the lessons don't change any in terms of what they're telling you.
Great, thank you. And then here's another question. I think it's for Dr. Padilla, but any of you can answer. Are there any good models for overall programs? That is, training all types of workers, or should it be done by discipline? What are the multi-state efforts? Dr. Padilla?
Thank you. Yep. There are a lot of models out there with varying success on how they approach this. So there are successful ones for nursing in partnership with academic institutions, for residency programs. It really, and I think this is related to another question that was in the chat, where do you start? Overall, I would say, where do you have the most capacity to begin, right? Because I think if you're looking at THC, GME, and graduate medical education writ large, that's a steep effort. There's a lot. On the nursing side, it might be lighter. On the behavioral health, it might be lighter. We've seen health centers start in various points, whether it's in nursing or behavioral health or community health worker, other allied health. It really is more of where do you have the most capacity, and then could develop and enhance beyond that. Because I think starting from ground zero is probably pretty challenging, but taking stock in terms of what you're currently doing. I mean, again, the fact that so few health centers that responded to that survey said we're not doing any at all means that many of you are already doing some, whether it's ad hoc. And I remember my time at Unity, we would have students come in all sorts of doors. And sometimes I'd say, who are you from? Where are you? We didn't have a handle on who was coming into the health center to be educated and trained. There's a first point. Like, where are these various entry points? Because what I saw is there's a clinician who had an affiliation with some school, and they said, hey, I'll take one of your students or two of your students. There needs to be a more coordinated, centralized process. Like, what are we currently doing in this space that we can better organize and coordinate? And we began that process at Unity, and we're better for it. So I would say, where are you now? Where's our biggest capacity? And let's flex that muscle rather than perhaps maybe creating all brand new ones.
Thank you, Dr. Padilla, and thanks for linking up all the questions. I really appreciate you keeping on top of the chat. I know that we're getting to the end and want to be respectful of your time, but I thought maybe one more question for all three of you. So for the last question, and this could be serious or fun, what advice would you give those of us in health center leadership trying to navigate this workforce crisis or challenge situation? And I know it's a hard one. Jim, do you want to go?
So, I think we're all struggling with it. I think, everybody is tired. Everybody is, trying to figure out what's the next right step. And I think what's most important is just to gather your teams around you, talk about what are the issues that are facing your workforce, coming up with plans of how to do it, both in the short term, the medium term, and the long term. And how do we energize and honestly get people who are, at least in my case, a lot younger than I am, in the door and into the program and into leadership, to really support them for the future of the program. I will tell you, I was just walking around the hallways here and I saw a whole set of younger folks that were in the Bureau of Primary Healthcare, and I, got to talk to them and they were so excited. And it's like, how do we make sure we keep that momentum and that enthusiasm that, the next generations are going to have, and how do we create an environment to support it? And then honestly, like amongst ourselves, how do we recharge and support one another? So I wish I had like a magic wand, but I think it's just us working together and figuring it out together.
Oh, that's great advice. Want to see Tom? Did you want to share your advice?
Well, it's herding cats, right? I guess if you're good at that, maybe you could pull this off. I'm not really sure. No, I mean, I think, the one thing when I've done site visits that I'm continually try to remember is that people get excited when students are rotating through. To Luis's point, it's nice when you know why they're there, sure, but I think that being an educator and being a way to groom the next generation can be a motivator, and it can create a sense of energy in a clinical setting when I've been to both hospitals and clinics. And so, how do you build on that? I don't think any of us, see this as anything easy to do. Yet at the same time, what option is there but to plunge ahead and try new ideas?
Great, thank you. Dr. Padilla?
Yeah, as Jim and both Tom said, this is a big task. It's not easy. But I would say that, from a leadership perspective, I think leaders need to be on board with the investment in education and training. This is an investment. Just like you're investing in quality healthcare delivery, there needs to be an investment in quality education and training. I think the worst thing an organization could do is expose students to an organization that isn't ready for them, that isn't coordinated, and it doesn't have happy, or I should reframe that, joyful staff. Because when you do that, what we see time and time again is, just like everything else, you look at who's there. Is that the job I want, where I want it when I'm done? And if we're not showing the best side, and certainly we look at this from our funding opportunities, be prepared to do what you want to do. And if you're not, I think these future students and clinicians are going to make decisions elsewhere. They're going to say, I don't want to go into primary care because that's the way I'm going to be treated and worked and overworked. I don't want to go into a health center because they're not ready for me and they don't care about me or whatever. And I think that the mission part of delivering healthcare translates and could translate to education and training. I think that part of it comes out in whether it's Jim, us, Tom, what we hear over and over again, I'm here because of the mission. So I think you can draw those people in and you can draw students in, but they want to see a long-term investment here. They want to make sure that, this is an organization that I'm going to spend 5, 10, 15, 20 years at. So I think from a leadership perspective is, if you're going to make this investment, think about it. What's your wheelhouse? What's your strength? And show the best side of the organization that you can to your future workforce.
Right. Those are really wise advice. Thank you so much for making time for this very important summit. I know that there were some questions that we couldn't get through too, and then also some great comments. So we'll try to get a copy of those to you. But again, I just really want to thank you all for taking time to speak to all of us. And we look forward to hearing from you again in the near future. Thank you. And thank you. And with that, I think I'm going to pass it back to Gerard.
Thank you so much too, Jim, Dr. Padilla, Tom, really appreciate you. Always willing to come back for this summit. Now I think this is the 3rd or 4th time in a row. So we greatly appreciate you for your support for the health centers and certainly for this summit as well. And now I'm going to turn it to Dr. Grace Wang, who is the Senior Fellow for Public Health Integration and Innovation at NAC, and who will be moderating our next session. Dr. Grace?
Thank you, Gerard. Are my co-presenters here, Dr. Bannister and Wartworth Finley? Yes, great. So hello, everyone. I am so pleased to be here. And I am a senior fellow in the Clinical Affairs Division at NAC, and I'm going to introduce our presenters, Wartworth Finley and Dr. Guardia Bannister. So Dr. Guardia Bannister is the Executive Director of the Institute for Patient Care and Director of the Yvonne L. Munn Center for Nursing Research at Massachusetts General Hospital in Boston. She's also the Connell Jones Endowed Chair for Nursing and Patient Care Research at MGH. She received her Bachelor of Science in Nursing from the University of Wyoming Laramie and has a PhD in Psychiatric Mental Health Nursing and a Master of Science in Nursing, Psychiatric Mental Health and Nursing Administration from the University of Texas at Austin School of Nursing. She's certified as a nurse executive, and she's a fellow in the American Academy of Nursing. She's got extensive recognition of her accomplishments and achievements that include the American Nurses Association Mary Eliza Mahoney Award, the American Organization of Nurse Executives Prism Award, and a Lifetime Achievement Award from the National Black Nurses Association. So welcome, Dr. Bannister. Wartworth Finley is the Senior Vice President of Workforce and Training at the Massachusetts League of Community Health Centers, where she oversees a team focused on a broad array of programs designed to recruit, retain, and develop a diverse health center workforce. She has more than 20 years of experience partnering with employer organizations to design and implement employee benefits and solutions that attract and retain critically needed workforce. Under her leadership, the Mass League is the only primary care association to receive HRSA funding to address workforce resilience at health centers. So I'm really looking forward to hearing about the great work our presenters are doing with this funding. Ladies.
Well, thank you so much, Dr. Wang, for that introduction. We are thrilled to be here today. So again, Wartworth Finley, Senior Vice President of Workforce and Training for the Mass League. And as Dr. Wang shared, I'm joined by my colleague today, Dr. Guardia Bannister, the Executive Director for the Institute of Patient Care at Mass General Hospital here in Boston. Thank you to the NAC planning team for inviting us to this year's Workforce Summit. Dr. Bannister and I are just thrilled to be here today to discuss the partnership that our organizations forged. So a primary care association and a world-renowned academic medical system came together to collaborate on a pilot program designed to strengthen well-being in the community health center workforce. So we can advance to the next slide, please. Today, we'll provide for you an overview of our well-being pilot program that we've developed with the support of HRSA funding. We'll also discuss how this collaboration was formed, some of the keys to our successful partnership, as well as some of the challenges that we've navigated in the process of engaging in this work together. And we hope by the end of this session that you'll have learned some strategies to building strong teams across disciplines and organizations, and we'll have gained some insights into developing an engagement strategy of your own that's centered in understanding what matters most to our health center workforce. Next slide, please. So as we all know, much was asked of our community health centers during the pandemic response. In addition to them remaining open for our patients' primary care needs, health centers diverted much needed significant resources to community-wide COVID-19 testing, contact tracing, and vaccination. And while we know it was the right thing to do, we've also come to understand that those heroic efforts exacted a toll on both our patients and on our workforce. And while the entire healthcare system is faced with ever-growing workforce shortages in the wake of COVID-19, health centers feel those shortages more acutely, because in addition to these unprecedented levels of exhaustion and burnout our staff have experienced, we simply can't compete with the enticement of higher salaries in other settings. And as our health centers navigate these staffing shortages, they're also dealing with increased demand from patients who deferred care throughout the pandemic, patients who already faced significant health disparities long before the spring of 2020. So that means that our staff are working harder than ever with greatly diminished support. And on top of all of this, our country is faced with a mental health crisis. So all of these issues require a myriad of approaches, as this audience knows all too well, including the need for greater investment in community-based primary and behavioral health care. And like all of you, the Mass League continues to explore new ways to support our community health center workforce through various supports and initiatives. But we also need some immediate solutions that can help us to strengthen, nurture, and retain our current workforce while also attracting new staff. So we believe that building a culture of wellness at community health centers can be one of those solutions. So as a primary care association, we recognize the importance of providing greater support to our membership as it related to wellness and well-being. And with that backdrop, in 2021, in response to a HRSA notice of funding for a 3-year grant entitled Promoting Resilience and Mental Health among Health Professional Workforce, the Mass League and Mass General Hospital teamed up to explore this grant opportunity and to discuss ways that together we'd be able to support the workforce wellness within community health centers. So we brought together a team of diverse individuals representing different disciplines, varied educational backgrounds, and work experience. And fundamental to this group's success was the incorporation of some guiding principles that my colleague, Dr. Bannister will share a little later. So this partnership between Mass League and Mass General resulted in our being awarded this HRSA funded project designed to identify and implement evidence-based programs that support resilience, wellness, and mental health among the health center workforce serving in rural and medically underserved areas of Massachusetts. And the program also aims to enhance organizational cultures at these health centers to move toward a sustainable model for enhancing employee mental health and wellness. We know without organizational culture being at the center of this, then we're really not going to have long-term change and sustainability. So we came together, we selected a few pilot health centers to partner with us on this journey. And these health centers range in size, the populations that they serve, and geographic locations. We wanted to ensure that we had diversity amongst the health centers that we chose for this work. And we've branded our program, as you'll see on our slides, Be Well Together, to really convey the idea that we're truly better when we collaborate and to build a sense of community. Next slide, please. So this is our timeline of our journey. And in 2022, we began the work of assessing the landscape of existing wellness resources. So what's already out there? What do people already have access to? And then later that summer, we conducted listening sessions to really help us assess the status of staff wellness and priorities at each pilot health center. The listening sessions were held with C-suite leaders and a sample of mid-level managers and supervisors so that we could collect more qualitative data on their individual perceptions of staff wellness at their health center. We also wanted to get a better sense of the current resources and programs that were available at community health centers. And importantly, we needed to know what were the barriers for accessing some of those resources and programs. These sessions allowed us to hear directly from leadership and from staff, and it helped us to guide the types of resources that we would soon implement within health centers. And in the fall of 2022, we launched an all workforce survey at each of those pilot health centers to determine baseline individual well-being and organizational culture. And based on those results, we've started our work, as you can see from the arrow there, with developing curriculum to implement programs within health centers. Next slide, please. So as we've discussed thus far, this grant was really designed to help health centers to begin the work of addressing the burnout, stress, and anxiety that was already present within health centers, but was exacerbated by COVID. It's our hope that by implementing evidence-informed approaches to improve the wellness and mental health of health center staff, then we're able to start enhancing well-being on an individual staff level and improve clinical workforce retention and patient outcomes overall. So now we'll talk a little bit about how the Mass League and Mass General were well positioned to take on this work, given our respective organizations' accomplishments. So one of the things, next slide, please. One of the things that makes our partnership successful is our organization's ability to rapidly deploy relevant resources. Over the course of the pandemic, both Mass League and Mass General quickly pivoted to be responsive to the needs of patients and of the workforce. Mass League leveraged virtual forums, we had learning sessions, we did role-based online communities to share information and foster peer-to-peer learning across health centers. The League also developed a playbook of best practices for health centers, and we use that to implement and promote COVID vaccine clinics and how health centers could stand those up on their own. Our deep engagement with our members enabled us to provide responsive support along with resources and advocacy at a most critical time. During that time in parallel as well, our colleagues at Mass General embarked upon their own initiatives in support of their workforce and their patients. So I'll turn it over to Dr. Bannister to discuss the parallel efforts that Mass General engaged in to support their patients and their workforce.
Thank you so much, Watura, and I just want to thank everyone for the opportunity to present to you today. And I can't help but notice all the shout outs to the Mass League Community Health Center that are in the chat. And I can just tell you, it has been such a privilege and an honor to be able to partner with this wonderful group of colleagues. Again, I'm from Massachusetts General Hospital. We are an academic medical center, and we have about 1,100 beds for patients, and we have about 50,000 patient admissions every year. We also have 1.5 million outpatient visits each year. And needless to say, during COVID, as Watura mentioned, we really did have to pivot. What's really important, though, is when I think about our Mass General mission, we have a mission to deliver exemplary clinical care. We have a mission to advance education, and I was listening to the earlier speakers talking about the importance of education. We also have a mission in regard to research, and we're one of the most successful hospital-based research programs in the country. But our fourth mission is to really support our community and the community of patients of which we serve and the community of which our hospitals and our other entities are within. So we were perfectly aligned to come together with the Mass League to be able to execute this HRSA grant. One of the things that happened during COVID, and as Watura said, we all had to pivot. So when we think about the fact that Mass General has about 30,000 employees working here in all clinical roles, and we wanted to make sure that we were touching everyone from leadership roles, clinical roles, environmental service roles, food and nutrition roles, everyone here that is part of our staff are critically important to our success. So we had to design and implement and really think about well-being and resiliency programs. So we were able to offer just-in-time programming. We were able to look at what we wanted to make sure was going to be influential, not only in our clinical environment, but how did we want to make sure that we took care of our workers who were going home. So we had stress management, resiliency, meditation sessions, all kinds of different offerings that we were able to not only bring to our employees here, but also help inform the work that we're doing with the Mass League as we think about potential interventions for the 4 pilot health centers that we're working with. The other thing that we thought was really important was the availability of hotlines that we had in place that we think that we can quickly pivot for our community health colleagues that are part of the Mass League program, also peer-to-peer coaching and support, and all of the interventions that we're thinking about are evidence-based. So there is a science that goes along with many of the initiatives that we are implementing and plan to implement over the course of this 3-year grant. So next slide. So I think I've been able to articulate that this HRSA grant was really the perfect opportunity. And again, you'll see it's entitled Promoting Resilience in Mental Health Among the Health Professional Workforce in Community Health Centers. We have the amazing expertise of the Mass League of Community Health Centers and the incredible work that they've been doing. We had the also wonderful expertise of Massachusetts General Hospital in regard to the suite of well-being and resiliency offerings and programming and initiatives. And we were able to come together under one umbrella to be able to execute this grant. Also, it was very helpful given that what I said earlier in terms of our research infrastructure and our research expertise and experience to be able to bring bear for that as part of this grant as well. Next slide. So I want to talk a little bit about how we work together, because I think what's really important and for all of you to hear is that we've decided that we needed to be very intentional about our work together. When we were initially responding to the RFP from HRSA, we had never met in person. And for the first year of the grant, we were not in the same room together. So very much like this conference today, we were in our little boxes, meeting each other, getting to know each other. And I think I can share, at least from my perspective, it's very different when you're in the room and you can see all the body language and you can really have a connection versus the opportunity to work together virtually for such a long time. So we have Watura and myself, we're really the project directors or managers, and we meet on a regular basis. And I'll talk about this in a future slide, but I want to emphasize it right now, is the importance of our working relationship. We have wonderful communication. We're honest with each other. We trust each other. And we actually just have this, it's just been, as I said earlier, a privilege. We brought our project teams together, so we have regular weekly meetings where we're really going through. We look at the objectives that we've established for our HRSA grant, and we want to make sure that we are tracking them on a regular basis. Are we meeting the objectives? Are we making sure that we have in place the infrastructure to be able to, at the end of our grant, deliver the important outcomes? And when I say that, what I really mean is we want to make sure that this program has really a sustainable impact on the community health center workforce. So at the end of the day, it's wonderful having this grant, but it's really the people that are on the ground that are delivering the care or cleaning the floors or answering the telephones. We want to make sure that what we have done will be impactful for them. We also have core project team meetings, and you'll see there's a lot of meetings here, but what we found out is with some of these team meetings, it's important to be able to divide the work. And so we have expertise on our team that are researchers. We have experts in terms of the culture of the community health centers. We have an expert in terms of evaluation. So what we try to do is sort of divvy up some of the responsibilities, but then we come together. We also decided that we started to implement quarterly in-person meetings. And I can tell you our first in-person meeting, which really wasn't that long ago, it was such a wonderful opportunity to meet everyone in person. We had some icebreaker activities so that we could get to know each other better. And it really helped we already had a very well-formed team, but it helped to solidify it even more. And then also one of the things that's important with a project like this is to make sure that we have the ability to collect all the resources and the materials in an organized fashion. So we use SharePoint, we use Dropbox to be able to make sure that we have all of the documentation that's required going forward. Next slide, please. Also, I wanted to share some of our tools for success. And as Watura mentioned earlier, we really are coming together and we have shared values. Our mission and our dedication is to our communities and our community healthcare workforce and our clinicians and all of our staff that are delivering this exemplary care. The other one, and I'll go through some of the other areas of missions and goals that we have, is equity was always something that we talked about at the very beginning of our work together. We felt like it was so incredibly important that we have a program that was equitable in terms of ensuring that we had resources that were in multiple languages, that when we were executing some of our surveys, that we wanted to make sure that anyone, whether English was their second language, that they were going to be able to participate. One of the things that we also looked at is we developed what we call team norms. Because as you're coming together as a team, as I said, we hadn't been together in person for over a year. We were doing this incredible work together. We did have these shared values and this mission, but we also wanted to make sure, because we were different and we were coming from a different lens and different perspective, that we developed some team norms. Some of those norms are, and I won't go through all of them with you today, but we wanted to make sure, obviously, that we treated each other with dignity and respect, that we also valued this incredible partnership and this opportunity to be able to come together, that we wanted to ensure, as I said earlier, that we wanted to make sure the health and well-being of the community health center workforce, we wanted to make sure that that was always fundamental and our North Star in regarding to the work we were doing. Again, I mentioned equity, and again, being intentional. I think that these things don't happen by themselves. They don't happen happenstance. So we wanted to be intentional going forward. We also incorporated team building exercises, and then we wanted to role model wellness. How could we possibly ask our community health centers to implement some of these initiatives without being able to walk the walk and talk the talk ourselves? So we make sure at the beginning of all of our meetings, we role model wellness. And that may be today, I'll give you an example. We had a wonderful wellness exercise where it was, I think, someplace in Denmark, where this person was laughing and everybody on the train started laughing too. It was really, really infectious. And we know that that has the ability to really increase our endorphins. And then lastly, and I think also equally as importantly, Watura and I have such a trusting relationship. So we can talk about anything. We manage conflict together, and we've been able to, I think, successfully manage so far 18 months into this really important initiative. Next slide. Watura.
So thank you for that, Gordia. And well said. We do have a great relationship, and it's really helped our teams to continue to grow and develop through this process. And as Gordia mentioned, our North Star is at the center of our work is what's best for the health centers. So we can't do this work effectively without our partnership of our health centers. And we've utilized a multifaceted approach to engaging with our health center partners. So first, we worked with our pilot health centers to identify and designate an executive sponsor and a project champion. The project champion is really our main point of contact and partner in implementing interventions on the ground. So we coordinate with that person for on-site events. We share promotional materials and strategize our outreach with our champions. And then the executive sponsor at the health center plays the role of providing systemic and institutional support, the support that's necessary to move the needle for many of these interventions. They also help us to decipher how best to support wellness through the leadership at each health center. It's critically important that we have leadership buy-in, and oftentimes the executive sponsor is not at the highest level in the organization, so they help us to decipher how best to support wellness through the leadership lens at health centers. We've also assembled an amazing advisory committee comprised of leaders within the health centers. So our pilot health centers, and then we have a handful of other health centers that are not participating in the pilot, but serve on our advisory. And then we have wellness leaders from Mass General. So specifically leaders from various departments across Mass General in nursing, psychiatry, medicine, spiritual care, social work. And these members were selected because of their deep experience with developing and implementing programs for healthcare workers. We hold quarterly meetings with our advisory, and their collective expertise and input has been extremely valuable to us in this process. They've served as a sounding board for us, really helping us to move forward with our ideas, to navigate any challenges that we might have. And they've also just been a great support system, cheering us along all along the way and giving us the much needed commendation when we're going through some difficult challenges in the project. We have designated members of our project team, both from Mass League and from Mass General, function as a dyad in holding standing meetings with each health center. So this group plans, coordinates, and attends regularly scheduled meetings with our champions to share updates and exchange ideas. But most importantly, these meetings really allow us to keep the lines of communication open with our health centers. It allows us to serve as an extension of the health center's organization. And most recently, we developed another tool to aid in our engagement. And we call this BEST, Brainstorming Engagement Strategy Tool, and we'll show that on the next slide. But this tool helps us to guide our meetings and next steps in shaping and implementing interventions within the health centers. Next slide, please. So this is an eye test, so we won't ask you to read what's in these columns, but this is a screenshot of our brainstorming engagement strategy tool that we've developed. And this tool is the mechanism that we're using to identify priorities and opportunities to engage with each health center. And the first column lists every potential intervention that's been proposed over the course of our project. So those results that we had from our listening sessions and our survey responses. And then we allow each health center to rank their interest in ideal timeline for implementing a given intervention. And from there, it allows our team to get a better sense of each health center's priorities and have an ongoing dialogue with them about how we can support them moving forward. And in a few minutes, Gordia will share more about how this framework has helped us to better understand what we call what matters most to our health centers. But first, we'll discuss what we've implemented thus far, given our engagement together. Next slide, please. So we started developing interventions earlier this year, as you may have seen from our timeline, and we've implemented a combination of interventions tailored to the specific needs of health centers. But then we've also looked at shared interventions that can be used across all of our health centers participating. So for the tailored interventions, we really try to meet health centers precisely where they are and fill in wherever we can be helpful. So for example, last month, members of our project team participated on a panel on stress management during a lunch and learn hosted by a health center, the health center staff engagement team. And we were able to hand out physical materials and resources such as guided meditations. We had some journals, breathing and grounding exercises, complemented by a discussion on how to integrate mindfulness exercises into a busy workday. And then tomorrow, we have quite a busy team. Tomorrow, we're holding a wellness fair at another one of our pilot health centers. Our project champion suggested it during one of our standing meetings, and our project team quickly worked together to put together the logistics for this wellness fair. And so our Be Well Together team, alongside wellness experts from Mass General and community partners, will participate in this wellness fair tomorrow. And then, as we all know, each health center is unique. So some health centers are just starting to think about how to integrate well-being into their strategic plan, while others are more advanced in their planning. And so again, we meet health centers wherever they are. So we have one pilot health center who already started to prioritize well-being within their center. And they see Be Well Together and the work that we're doing as a complement to their existing strategies. They most recently consulted with an organization that's helping them to develop a program designed to help staff learn the connection between mind, body, and breath. The program teaches individuals how to use natural, specific rhythms to facilitate the release of deep stress. And since this program nicely aligns with the overall goals and objectives of the HRSA grant, our Be Well Together team will be supporting the health center in implementing this program within their center. So these are some examples of some tailored interventions specific to that particular health center that we are able to implement. And then we have shared interventions, and these are resources and interventions that all of our pilot health centers have identified in their baseline survey as particular areas of interest. So for example, we just held at the Mass League our annual Community Health Institute conference, All of our health centers are invited to attend that. And there we set up a wellness room at the conference site to model simple and affordable interventions that can help incorporate a little joy, a little peace into a health center staff's busy life. It was a space where conference attendees could take a breath, they could step away from the lively conference just to relax, and while there, pick up some materials and learn more about incorporating well-being into their day-to-day lives. This is an example of a shared intervention or shared resource that would be applicable to all of our health centers. And then later on this month, we're holding a financial wellness series for our health center staff to attend. What came out of some of our surveys, top common theme was around financial wellness and well-being, that staff were really interested in getting more resources and tools to help to support their financial well-being. So we've set up a series around financial wellness. And again, this is based on community health center feedback. And we're holding this session as a lunch and learn, and then we'll hold it again after hours, and then a third on a Saturday so that we can expand our reach. So we really want to, again, ensure that we're meeting staff where they are and providing flexibility in some of the resources and tools that we're providing for them. And we also plan to make recordings of this series, as well as host other wellness resources to health centers through a central website so that they can access these resources. So while our team has accomplished a lot in a short period of time, it hasn't been without challenges. I'm going to turn it back over to Dr. Bannister to discuss some of those challenges and how we've successfully navigated them.
Thank you. Again, as Watura said, we've done a lot together, but there have been these challenges. And the great news about all of this is that we continue to work through these challenges together. First of all, because this is a HRSA grant and we need to go through our institutional review board in terms of IRB approval for all of our resources, materials, surveys, everything that we're using in regard to the grant, we have to run that through our review board. As a result of that, as we were developing our instruments and really thinking about our baseline survey that we conducted, the listening sessions that we conducted with the leadership and mid-level managers, all of those things had to be approved through our IRB. What we found out is that in addition to the time that it took to be incredibly thoughtful with our community health center partners about what information was going to be included, it also takes a while to be able to get that approval through the IRB because obviously they are reviewing multiple studies from across our system. So what we found is that sometimes there was a delay in our ability to get our surveys or our IRB approval through because it just took a little bit more time than we anticipated. With that being said, however, once we did receive IRB approval, we quickly then pivoted and started the implementation phase. The other thing that we learned is really the importance of understanding the rigor of our scientific inquiry. And then we wanted to make sure that we balance that with the sensitivity of what was really important to our community health centers. So for instance, let me give you an example. Some of the researchers on our team, it was really important and they were very interested in, for example, getting the 9-digit zip code numbers of the participants in the study, because it would give us an opportunity to really then understand and do some mapping of understanding essentially what resources may be available in certain areas, what income levels as an example in other materials. At the same time, when we were talking to our community health center colleagues, they felt very strongly that maybe this asking for that information might really prevent some of the community health center workers from being able to complete the survey because they felt like their confidentiality in some way may have been violated. So we had multiple discussions between our project team, our community health center colleagues, and really trying to understand with our colleagues of the Mass League, helping to guide us understanding the cultures of our community health centers, what really might be best. So we did a lot of modifications in regard to making some of the questions on our instruments being optional versus required. And then we also did the due diligence with our advisory board that we actually shared our survey very widely so that we could get a lot of feedback about whether this was going to be something that our community health center workforce was going to be able to complete. We also wanted to make sure that as we were thinking about the rigor and the sensitivity, that we were able to implement the survey in other languages. So there were 3 other languages that we also had the ability to implement the survey, so that we made sure that we were paying attention to the needs of our healthcare workforce. The last thing that we also did as we were making these edits is really, again, taking the time and the due diligence to understand the culture, understand the needs, and we didn't want to have anything that was going to be perceived as overwhelming, and I'll talk about that in just a minute. Again, as I said before, really understanding our primary care association, the Mass League, in terms of their perspective, and they were so helpful in terms of guiding this important work, because we at Mass General don't have the experience that they have with the community health centers in really understanding their cultures. So a lot of due diligence, a lot of good time that was spent, but I think that our outcomes will definitely demonstrate that having taken that kind of time and being due diligent is going to be better in the long run for our outcomes. We also have, over the course of the last 18 months, had turnover, and we've had transitions in our team. So again, going back to a comment that I made earlier, the importance of being intentional. As we've had new members join our team, we've really put together a very comprehensive orientation to our Be Well Together initiative, so that they don't necessarily feel like there's this sort of, they're dropping in a program that they have really no background or information about. So we've been intentional about the orientation process. We also have a binder of our grant that we ask them to read, and we really go through and make sure that they have a very comprehensive understanding of the work that we're currently doing, but also the history of the work. How did we get here over the last 18 months? Then lastly, in regard to the survey, one of the things that we found out, and we needed again to be sensitive to our community health center workforce, is that some had already conducted surveys. So they were very concerned about survey fatigue and not wanting to over-survey their community. So we delayed, in one instance, the survey for almost a year before we implemented it, because we wanted to be sensitive to our community health center. We also looked at the number of questions on our survey as an example. We also looked at the timing. And we also, something that we talked a lot about is preparing the environment. So preparing the environment means communication from leadership that the survey is coming. Preparing the environment, letting them know that the survey only takes 15 minutes or 10 minutes. Preparing the environment in terms of having on-site champions that are really the cheerleaders for please complete the survey, because it's going to be helpful to you in the long run. So while this slide is talking about overcoming challenges, we had those challenges, but I'm very happy to say that we were able to and continue to overcome some of the barriers that come our way. Next slide, please. So I also heard this as our HRSA colleagues were ending, in terms of the importance of joy in the workplace. And so that really leads us to really thinking about, for our community health centers at the end of the day, what really matters to you. And we've certainly taken this initiative from the Institute for Healthcare Improvement that actually put forward what matters to you several years ago, and really creating a culture of wellness. So we see, as part of this initiative, really having, in addition to what's already been presented, we know that our community health centers, they already have resources to promote a culture of wellness. What we want to do is be able to build on those resources, understand how we can amplify or catalyze what you already have in place, and then how we might enhance any additional resources they might need in terms of looking at the gaps. We also know that it's really important to let's leverage our community resources. What's around our community health centers? So for instance, if there's a food bank, if there is a farmer's market, are there other resources that might be available that will be really important to the staff to be able to take advantage of? We want them to be able to do that. One of the things that came out in the survey from some of the participants is feeling like the resources were really for the patients that were being served, or the clients that were being served. They weren't quite sure that some of those resources they could use for themselves and for their families. And we're really trying to dispel that the resources that we're bringing to bear are for everyone. and then really to integrate system changes. And what I mean about this is the importance of not just initiating initiatives, but we want to have sustainable change in our community health centers for a culture of wellness. So what other kinds of systematic changes need to happen within the community health center to be able to sustain and promote this culture of wellness, whether it's programs, whether it's initiatives, whether it's resources, where it's other things that may be causing pain points. How can we resolve and support them going forward now, 18 months from now, and also well into the future? So next slide. Now we're ready to take your questions. And again, thank you for this opportunity.
So thank you, Dr. Bannister and Watura, for that presentation. We do have a question in the chat. How are you planning to measure the success of the interventions? Specifically, how will you measure the impact of the interventions on mental health, resilience, various dimensions of wellness?
So I'll start off, and please, you can call me Gordia, and then I'll have my colleague Watura also share her thoughts. Clearly, everything that we are implementing, there is an evaluation component that goes along with it. So again, in addition to measuring, obviously adoption of some of these initiatives in terms of the number of people that attended, and again, their perception of those interventions, we're going to be measuring, and we did our pre-survey, our baseline wellness survey. The idea is to do a post-survey of that baseline wellness survey, which is going to ask questions about stress. It asks questions about burnout. It asks questions about the environment of wellness within the community health center. So we have a very robust evaluation plan that is not only topical in regard to the programs that we're offering, but certainly towards the end, we're going to be evaluating the whole initiative. And also part of the evaluation has to do with sustainability as well.
And I'd only add to that, Gordia covered it very well, is at the end of every session that we have or an event that we have, we are asking questions around satisfaction. We're looking for that feedback from our participants to understand if we're really having the impact that we intended to have. And then, as Gordia mentioned, our post-survey is also another way that we'll understand the full scope of the true impact that we've had through this work.
Great. There's another question. What was your goal percentage for survey participation, and what level of participation have you seen in the wellness activities that have taken place?
So I'll go ahead, Watura.
No, go ahead, Gordia, please.
So first of all, our goal would have been to have everyone within our community health centers complete the survey. But again, as we were talking about, there were other surveys that were in the field. We were trying to be very sensitive to survey fatigue, which I feel like some of our community health center colleagues were experiencing. So right now, some of the surveys that we've conducted, we have about a 25% response rate, which is not too bad when you think about the context of everything that we have been through. In regard to our individual initiatives that we have just started and just launched, we've seen tremendous excitement, investment and involvement. So for instance, something that Watura talked about just a little while ago, where we hosted a panel on wellness that included talking about burnout and stress management. We also had a resource table that we actually, all the materials that we brought, they were all gone at the end of the programming that we needed to order more. So we're really seeing that in person, first of all, has been very, very advantageous for us. Did you want to add to that, Watura?
And one of the things that was important to us, as Gordia mentioned, that our work is grounded in equity. So while we looked at our responses, we were also very intentional about who haven't we heard from. So some individuals have responded to the survey, but others have not. And what are some of the reasons around that? Are those the ones that are truly tapped out and for whatever reason have not decided to complete the survey? And so for us, it's important to try to hear those voices as well. And we do that through our work with our champions. The survey was anonymous, of course, so we don't know who within the health center responded individually. individually, but we are seeking other ways to get input from individuals within the health centers. And then even some of the resources that we didn't hear, that didn't come through the survey, we're still sharing some of those because we understand that those are critical resources that health center workforce may want to use, regardless of whether they responded to that in the survey or not. So that's part of us using that engagement tool with our champions to really hear from them and understand, would this resonate with your workforce? Is this something that we can pilot for a short period of time, evaluate and see if there's interest? So we're using a number of means to be able to engage the workforce and measure our success.
That's great. I was sort of wondering how you all interfaced with the Bureau's workforce well-being survey activities.
Yes, thank you for the question. So that survey was in the field around the same time that we were putting out our survey as well. We had a staggered approach because various health centers were going through various organizational changes. One health center was going through an EMR conversion, and so it wasn't possible for them to give attention to a survey, to our survey, the Be Well Together survey at the time. So we staggered that. So the Bureau's survey was in the field the same time as some of our health centers surveys. And so it really necessitated that we meet with our health centers. And as a PCA, wearing the PCA hat, we wanted all of our health centers in Massachusetts to respond to that survey. We wanted their voice to be heard in the national survey. As leaders of the Be Well Together program, we wanted them to equally complete our survey so that we could hear really what they needed from an individual health center level. So it really required some education with the health centers, conversations around the importance of both of the surveys, also distinguishing the differences between the surveys and the value that they would get from completing both the health center specific survey through Be Well Together, as well as the national survey. And so we look forward to receiving the results at the PCA level that we could then explore and look for ways to incorporate some of those findings into the work that we're doing with Be Well Together.
Thanks. I think we're out of time. I want to acknowledge there is a question in the chat, so maybe y'all could help with that, maybe offline. And thank you so much, Watora Finley from the Mass League and Dr. Gloria Bannister from Massachusetts General Hospital. Back to you, Gerard.
Thank you so very much, Grace. Thank you, Dr. Bannister and Watora. Certainly appreciate that great information that you share with us. I know there's so much energy in the chat about that, so you'll probably hear from lots of folks after this session. I want to apologize. I realized that I overlooked the break after or in between the HRSA keynote in this session. So just want to give you folks a heads up. We'll have a longer break after the breakout discussion that we'll start here right now. So we'll plan to break for 20 minutes, starting at 2:45, I believe it is, instead of 2:55, and we'll go through 3:05. So I want to be supportive of workforce wellness in that respect. Right now, what we're going to do is you've heard some really thought-provoking and I think certainly beneficial information over the course of what we've heard from Watora and Dr. Bannister, and what we heard from our HRSA associate administrators earlier. So we'd like for you to have a few minutes to talk to one another, to reflect on what you've heard, and to really ask or discuss three primary questions. We'll get these posted in the chat for you. What is at the top of your mind when it comes to those topics? So what do they bubble up for you? And what is your health center or your organization already doing? And what might be working or what might not be working? And then lastly, what are you planning for the future? What might you explore based on what you've heard today? So what we'll do is we'll put you in breakout groups momentarily. We'll have a moderator in those breakout groups who will just help you make sure that you understand what the instruction is, which will be to identify a recorder that person will simply capture one or two key points from your discussion. Right, so identify a recorder. We'll have you have that individual, we'll have them share that in written format. We won't have you report out, given the amount of time that we have and the number of people that we have. We won't have a report out, but we'll have you capture those two key points from the discussion. So when you get in there, just introduce yourself to your peers by first and last name, title, and organization, and then go into your discussion after you've named a recorder for those key points. What's top of your mind when it comes to what we've discussed so far? What's your health center or organization already doing, and what's working or not working? And what are you planning for the future based on what you've heard so far? So with that, I believe we are in the process of putting the breakout groups together. Mariah, I'll ask you to let me know when we're ready to put folks in those groups.
All right, welcome back, everyone. I hope you enjoyed your break. Hopefully you got to stretch your legs and eat some food so you're fueled up for the rest of our day today. But I am so excited for our next presentation. We have a panel on pathways and partnerships, and really exciting that I've already seen some chatter in the chat regarding apprenticeship opportunities. So I'm really hoping you guys will find immense value in this presentation. But today we're fortunate enough to be joined by two different partnerships. The first is the partnership between Community Health Center, Inc. and Yale University for their postgraduate nurse practitioner residency program, as well as a partnership between Roanoke Community Health Center and North Carolina Community College on their apprenticeship program. And today's panel consists on a brief presentation from both partnerships on their history and the value of their partnership. And then we'll have plenty of time for questions, answer, and discussion. So we welcome you to put those questions and thoughts in the chat throughout both presentations so we can see them as they come through, but we'll save them till the end so our panelists can all answer and have adequate time to do so. But from here, I'm going to ask Michelle to please share her screen. And our first presentation is going to be from Charisse Corsino, the Program Director for Community Health Center, Inc.'s Nurse Practitioner Residency Training Program, and Amy Marshall from Yale School of Nursing. She is a Senior Lecturer and Specialty Director for the Adult Primary Care Nurse Practitioner Program. I'm sure they'll want to introduce themselves as well. So pass it off to you both.
Great, thanks, Megan. Well, welcome everybody. It's great to be here today to talk about our clinical academic partnership between the Community Health Center, Inc. and Yale University School of Nursing. As Megan said, my name is Charisse Corsino. I am the program director for CHC's NP residency program, and have been with the program for the past 9 years and with CHC going on 13 years. So I'm excited to talk to you about our partnership. And Amy, do you want to introduce yourself or you want to wait until you go? Okay.
Yeah, no, I'm happy to do it right now. So I'm Amy Marshall. I'm a senior lecturer at Yale School of Nursing. As mentioned, I direct the adult gerontology primary care program, and I teach in the family nurse practitioner program. And I've been there for in a full-time capacity for almost 10 years or so, give or take. And I was kind of attracted to this academic partnership and kind of spearheaded being the champion for the university on behalf of all the specialties we have. So that's me.
Great. We can go to the next slide. So for all of you on the call who don't know, Community Health Center, Inc. Started the country's first formal postgraduate NP residency program back in 2007, training family nurse practitioners. We now take family, psychiatric mental health, adult gerontology, and pediatric NPs each year. We also have a 1-year post-residency fellowship. So really developed this, Margaret Flinter developed this model of training to train new nurse practitioners who were really committed to primary care and community health to provide this transition to practice from these really great academic programs to these really overwhelming first years of practice with extra support and guidance. I won't go into all the details of the program, but I'm happy to share more information if people don't know what postgraduate NP residency and fellowships are. So a little bit about our partnership with Yale School of Nursing. I'm probably going to say YSN from here on out. It's an easy acronym. So Margaret Flinder, who I mentioned, is CHC's Senior Vice President, Clinical Director. She sort of founded the whole NP postgraduate training movement back in 2007, probably a little bit before. But she is a YSN trained family nurse practitioner. She joined CHC in 1980 as CHC's first NP in clinical practice, had amazing mentors sort of naturally, and had practice in community health, and then became a leader in our organization, and is still here. I think she's on the call today too. She took her first YSN student in 1981, and CHC has had YSN students ever since. And we take currently placements for both RN and NP students, started just with family nurse practitioners, and I think expanded out from there. Many of our NP providers at CHC are YSN alum, and some actually hold faculty appointments, so they're teaching at the school. And then also with our postgraduate training program, about a third of our residents sort of historically have come from YSN, including our very first cohort of 4 residents, which 3 of the 4 were from Yale. Obviously, proximally, it's very close, and we've had this great partnership sort of naturally. And they've always served as a really trusted partner for consultation and discussions around trainees and education, students, and other clinical workforce topics over the years. Next slide. So just some sort of data on Yale School of Nursing and University student placements. In 2022, there were 60. Again, you can see the distribution of family, psych, pediatrics, certified nurse midwives, women's health. So we're taking a wide range of different students in different disciplines. And this is a really great opportunity for the Yale School of Nursing students to get exposure to clinical experiences and community health in particular in federally qualified health centers. I'm going to talk more about this pathway of clinical rotation to residency and beyond that. And 18% of the students have completed 2 or more clinical rotations at CHC. So we have a really sort of cohesive partnership. I think there are particular students who really seek out these environments. They want to go and work with vulnerable populations. And so that's been a natural pathway for us. There's been unique collaborations along the way as well. And I think COVID really opened our eyes. And interestingly, our partnership started right before COVID. It started in 2019 and obviously in 2020 when COVID hit, but we had a really great partnership with Yale students, offering them opportunities to get involved with community-based COVID testing and vaccine distribution. So a nice way to, again, kind of create a partnership out in the community beyond just those formal academic clinical placements. So this framework I find really helpful for anybody working to develop their own clinical workforce pipeline. And it has just become apparent in my years of almost 10 years of doing this, especially with Yale, but broader beyond that. So it really starts at the student. We all know that students need clinical hours, right? And so where do they find those? The really great academic institutions create these partnerships so they have trusted partners to send their students out to, and they can vouch for the clinical experiences. So those result in the clinical placements. Again, I think Yale is a great partner because they tend to attract students that are committed to community health, and we've seen this really nice cohesion of alignment of our values and our mission and what we're trying to do. So these clinical placements develop out of partnerships. And what I have seen is this really nice, clear pathway for those clinical placements be an exposure point for people who get exposed to doing a postgraduate residency. So what I have seen in recruitment and talking to candidates is they do a clinical placement either because they knew about Community Health Center Inc. and sought it out, or they just got placed there and said, I didn't know this is what primary care could look like. I didn't know this is what community health looked like. And they are either at a site that has current residents, or they are working with somebody who maybe was a former resident and who is now practicing at another site. And then they get to have these sort of organic conversations about what postgraduate training might look like, the pros, the cons, the value that it provided for that individual they're working with. I actually just talked to a candidate in this recruitment cycle who told me a story about she did her clinical placement at one of her sites and everybody ate lunch together. People were going on walks together at lunch, and she felt this like really nice community feel. And so having some real life experience in these locations helps connect them to what their practice might look like. And so this clinical placement has been a natural pathway, especially for Yale, but outside of Yale as well, for our postgraduate residents to come to our program because they know what it looks like. Our postgraduate residents are in sort of a 2-year agreement where they do 1 year of residency training and then stay with and work with us for a year in their first year of full-time practice outside of that. So these residents become full-time providers. So those residents have been modeled what preceptorship and mentorship looks like. They've gotten this amazing additional training to really allow them to practice at the top of their license. And then they take students and they take residents and they are didactic presenters. And so we are creating this sort of full circle, self-fulfilling pipeline of people who not only become the providers, but are capable and able to train more students. And so that has been really helpful, not to just continue to take our students from Yale, but expand the pool of people that we're able to support in the community and expose them again to community health and FQHCs. So just a little bit of history on the development of this formal partnership. And as the history shows, we've had this long-standing informal collaboration and partnership. But HRSA released a formal grant funding back in 2019, specifically for NP residencies and fellowships. This was called the Advanced Nursing Education NP Residency Program, or ANE-NPR, and it required a formal clinical academic partnership. And so we had never had a formal partner. We have great relationships with our academic institutions locally, but when we started thinking about who might be the right partner for this, Yale was sort of an obvious choice for us, just based on all the history that I went over. And so at that time, we formally partnered, and then in 2020, HRSA released a second round of funding, really similar, but also separate, the ANE-NPR IP, which stand for Integration Program, and focused a lot on telehealth and behavioral health integration. And we were really able to build upon our current partnership that we had developed in 2019. And I know Amy's going to cover more about sort of the process, but one of the things in terms of the basic overview of establishing this partnership, I think, again, we have great academic institutions, and I'm sure all of you do have multiple options for partners. But I think for us, one of the big things was alignment of mission and values. And what we had seen from the students that became residents from Yale is they were really aligned with how Yale teaches and attracts students, with the kind of providers that were invested in community health and the patients that we're serving, that really served nicely to create this partnership. And so it allowed us to really kind of talk in a way that we knew we were serving a very similar kind of candidate and applicant for both their program and our program. And so with that, I'm going to turn it over to Amy to talk a little bit more in detail.
Great. Next slide. So yeah, as I mentioned earlier, I became kind of the champion for the School of Nursing for this academic partnership. And some of that stemmed out of interest in developing the curriculum for the adult gerontology residency that they have. And I also teach in the family program, which is a pretty well-established residency that CHC has. So I really enjoyed having this role. And what I did was I communicated regularly with the lead clinician who oversees the residency program for the family and adult gerontology residency track. So we would have meetings monthly. We just have them on the calendar, put a bunch in a row. So we made sure that they were on the book, so to speak. And it was mostly just a lot of updating, but a lot of resource sharing. So I remember at one point the residency was looking at how to integrate more nephrology, clinical experience with their residents. And so we were able to connect them to one of our current clinical preceptors from the School of Nursing, and she's faculty too. And so the residents were able to go and have a clinical experience at that nephrology site. Other things we would do at our weekly meetings is just kind of catch up on what was happening with like the recruitment for residency and what's happening in the world of academia, which we'll talk a little bit more about, just to kind of keep each other looped in on what was happening in each other's worlds. But I really felt that one of the reasons why this was so successful is because we did have a champion on each side that was motivated to kind of meet regularly and bring forth things from each institution that were needed to be addressed through the partnership. Next slide. Yeah, and as I mentioned, some of the things that, and it's certainly relevant, I think, in the world of residency, and this is why I think a partnership is super helpful, because it's good to understand where your new graduates are coming from and what's happening in that world. So one of the things where this partnership is so helpful is clinical hours, as the current guidelines for the National Task Force Standards, which is our certifying bodies, are we starting to require all NP programs to have 750 hours. So we're looking at making sure we kind of formalize our academic partnerships and utilize them to kind of negotiate that increase in hours. Another thing we've been focusing on is just increase in diversity of the NP workforce. So that happens at the School of Nursing through things like holistic admissions and paying attention to when we're hiring faculty and making sure that we're looking at creating a more diverse faculty and a more diverse pool of students so that the needs of our country can be addressed from our clinicians. And then the last thing, that really we kind of talk about and negotiate, and I don't think it's new for residency, but it's newer for nurse practitioner education, is moving more towards a competency-based education model where we're really looking at making sure that they are, each student that graduates aligns with the competencies needed to become a proficient graduate level nurse practitioner in their program. So those are some of the things we talk about in our graduate nursing education that we translate over to the CHC side of things. Next slide. Another great example of a collaboration. I mean, I have many, but I think this was one that kind of stands out, and I think we really kind of did well, is a collaboration of resources around simulation. So at about the same time that our School of Nursing was going through a curriculum revision in gerontology, CHC was also looking at how to expand their adult gerontology residency program and their curriculum. So it the timing was really great. And we were working on building a telehealth simulation. This was a couple years ago. So telehealth was kind of in the time of COVID starting to blow up. And we wanted to make sure we were starting to train our students, and the residency wanted to train their residents. So it was great timing. And we were able to take a case and basically, we modified it to a little bit higher expectations for residents than students in terms of objectives, but we were able to use a case together. And we used our simulation department at our School of Nursing to help train the clinicians at CHC that were the leads for developing and implementing the simulation with the residents. So it was great. We just pulled together our resources of clinical expertise and education expertise, and both the School of Nursing and CHC were able to have great simulation experiences out of that initial simulation. And then from that, I know that the clinicians at CHC have developed more simulations. So we're super excited that they kind of took those initial resources and have just expanded their development and implementation of simulation as a means of assessing competency. So it was great. Next slide. Yeah, as I mentioned, just a few other collaboration talking points. We talked about the specialty rotations earlier. And, we definitely share resources about, what's current in the curriculum, what's current in content. And similarly, I ask what's current in the workforce for what's going on with certain given clinical conditions, resources that are being used, that sort of thing. So it really goes both ways, which is nice. And yeah, I'm an adult gerontology background, so I spent a lot of time with CHE specifically on developing that residency. And then we also were able to have other, besides like that first example of specialty rotations, we were able to have one of our pharmacology instructors gives a great talk about deprescribing and polypharmacy in care of the older adults. So they brought that into the that talk at a higher level into the residency, which I think is just such a great talk for anybody in primary care. So, and then, building on the psych program. So just, engaging with the psychiatric mental health specialty to develop what they need for their residency program for CHC. So it's been a really fruitful partnership with lots of opportunities for collaboration, and really it goes both ways. Next slide.
Amy, do you want me to start and then I'll turn over for your side? Okay, perfect.
Sounds good.
So I think we've kind of touched on the value of these academic clinical partnerships. For me, I just think it has created a broader understanding from what is happening at the graduate level. They can actually tell us, especially when COVID was going on in multiple years, about what people didn't have access to in terms of pediatric placements, or they didn't get enough of this because of COVID placements. That way we were able to know what the sort of a weakness might be coming in, and we could put more emphasis in their postgraduate training towards those pieces, or a shift about their curriculum. I think simulation is probably one of the best examples of taking a modality that we really were not comfortable with or familiar with, learning from the Yale School of Nursing experts. They've been so gracious with their time and expertise on it. it was very two-way that they got to pilot a new case and we got to try it out. And we have trained 2 of our former residents who are serving in a grant role to really understand how we can use this in postgraduate training. They've created great simulations on adolescent suicidality and telehealth, like a very specific one that would be very stressful and high stakes learned if it was a patient in front of them. And they can do that in a safe, controlled environment with trusted faculty to help them debrief and understand what they can do differently when that patient does inevitably show up in front of them. So that has been really an exciting sort of collaboration that has, I think, moved us forward, and we are grateful for Yale. And they also got to visit this in-person simulation lab, which they have just the top of the line, state-of-the-art simulation lab that a community health center just wouldn't be able to replicate in full. And so we had our residents, some of who were Yale grads, got to go back to the simulation lab with those faculty members from our side and just practice some of those skills that they don't get enough of. And I think they were really grateful for that opportunity to really practice the skills. And I think it's created this continuum of education. We're all sort of invested in the workforce on a much bigger, broader level, and say, how can we make this a smooth transition from student to provider and share information both ways? And I think that that's been a lot of value for both sides.
Yeah, I completely agree with what you said. And I mean, from our side too, this academic partnership has allowed us specialty directors to get a better understanding of like what is in the curriculum for a residency. So I have, as a mentor, as an advisor, as a specialty director, I have lots of students, you know, that should I do residency? What does that look like? I'm not sure. So I'm able to really give them some direct feedback about what that looks like. And, you know, because of my regular meetings with CHA, I was able to understand the application cycles and how that works. And so really, it just became such a fruitful opportunity for me to gain understanding of residency, because there are quite a bit of our students, particularly in FNP, but both in family and adult gero, go into residency post-graduation. So for me as a faculty member to have that knowledge was really insightful. And, you know, the other thing too, is knowing what's in the residency, I can better steer them, you know, into kind of developing their area of interest. So one of the examples is at Yale University, we have a Haven Free Clinic, which is a student-run free clinic for primary care. So a lot of the students that end up doing residency through CHC or otherwise oftentimes volunteer there, because it's very similar to what they're going to see in a community health clinical experience. So that's been really helpful to kind of be able to offer that to them as something to kind of help build their experiential learning. And then the last thing, which is one of the more recent things, is just the access to clinical resources and clinical experts. We right now are revamping our primary care curriculum at our school. And so we have a sense as faculty of what we want that to look like. But the next step after our faculty kind of sign off is we're going to hand it over to our academic partners and say, you have them look at it too and say, you know, from a clinical perspective, do you think that this is meeting the need of a graduate for primary care? So it's really just, it's bi-directional, this partnership, and I'm just so grateful for it. I think those are all our slides.
Awesome. Thank you to you both. We're going to pass it off to our next partnership, which is Stephanie Wharton, who is the Chief Operations Officer at Roanoke Chowan Community Health Center, and Tony McKnight, who is the Regional Apprenticeship Consultant with the North Carolina Community College System. And they're going to touch on their partnership as well. I just wanted to provide a quick reminder to please put any questions in the chat for any of our presenters, and we'll get to those at the end, and we'll have some time to have those discussions. But I will pass it off to our next 2 presenters.
Good afternoon. Thank you so much for the opportunity to speak about the Roanoke Chowan Community Health Center's workforce development and apprenticeship programs. I am Stephanie Wharton, and I am the current Chief Operating Officer at RCCHC, and I am the former Chief Nursing Officer. Next slide. What I learned through the COVID-19 public health emergency was that adversity is an excellent teacher and exposure of leadership mindset in crisis situation. And for us, our CCHC located in Eastern Rural North Carolina, staffing and the critical need to care for patients, both from the COVID-19 scope of work standpoint and to maintain our normal clinical operations, became a crisis situation due to staffing elements. As you know, in rural health, it's sometimes very difficult to recruit, retain, and also identify skilled staff to care for our very vulnerable populations. Next slide. So what I learned in the rural health pandemic management is that the shortage around North Carolina workforce staffing was not a new phenomenon. And actually it had been going on for several years, but it was elevated, especially as it relates to equity and access to care during the COVID-19 pandemic. Next slide. So Roanoke Chowan Community Health Center, established in 2007 as a FQHC. We have 5 locations. Primary population served are African American, and we are a migrant farm worker designee. We found that it was very difficult for us to maintain the stamina due to burnout and other issues around our staffing. We needed to come up with some solutions. And so what we decided to do, because we never closed our doors during the pandemic, we were providing virtual telehealth care, but we were seeing patients face to face throughout the entire time. Next slide. We leaned into our mission and our vision to provide great care for everyone every day, but what did that really look like for us? Next slide. We also looked at how do we empower a skilled workforce, and also lead through our mission to ensure that we were doing everything we could to maintain care and access to the critical populations we serve. So we looked at the NAC pillars to drive some of those solutions. Next slide. What we knew was workforce development was something that we could expand upon, but looking at it from an internal standpoint. We were not in a position to use staffing agencies, and oftentimes those agencies did not have the certified medical assistants that we needed, and RNs and LPNs to support our care. And so we looked at apprenticeship as a pathway to create opportunities for our own staff to upskill in occupations once we were able to enroll. We also looked at the socioeconomic injustices experienced by rural communities and how we could help. Next slide. Our first pathway developed was with a partnership with the National Institute for Medical Assistant Advancement, NEMA, who is also a partner of NAC. NEMA offers a certified medical assistant curriculum completely online. We decided to partner with NEMA and to fully fund 3 of our staff members who were currently working in CNA roles, certified nursing assistant. We funded them with $7,000 of tuition money to complete the 29-week program, and this innovative approach proved to be transformative. Next slide. So what did we need? I needed $20,000 to really support this program for the initial seed money to get this program started. So I spoke with the executive leadership team, came up with the business plan, and was funded $20,000. Next slide. With that $20,000 funding to pay for the tuition of our student staff members, we also decided to decrease the staff members' weekly hours from 40 hours to 20 hours per week, allowing 19 hours to complete their education, therefore removing the barrier of trying to manage home and school so that our student staff members would be successful. We funded $129,488, which also included our employee wages and benefits. We paid tuition, $27,760. And with NAC's help, I was able to apply for a grant through Johnson & Johnson, which gave us a little grant money, $10,000 to support the program. Next slide. We also decided to explore becoming a registered apprenticeship employer. As a registered apprenticeship employer, we look at what we need to develop a skilled workforce, develop customized training pathways that will help to retain our workers and also increase and expand diversity. Next slide. There came the partnership with Mr. Tony McKnight. What a great partner through the North Carolina Community College System and North Carolina Apprenticeship Program. I can't say more about what this partnership has done to not only expand and further upskill our staff members in multiple occupations. Tony, take it away.
Thank you, Stephanie. I'd just like to just give Stephanie kudos of how we've actually been working together. We've actually started the program back in 2021, and we've had a strong relationship ever since then. Again, my name is Tony McKnight. I'm with the North Carolina Community College System Apprenticeship NC. We're the state approving agency for a registered apprenticeship here in North Carolina. We have, just to give you a little background, I've been with the organization for probably 18 years, so I'm a little senior. I'm a senior consultant on the staff here in North Carolina. Next slide. So there's three, the main topic is the elements of a registered apprenticeship program. There's three components of the registered apprenticeship program itself. It's the classroom-related instruction where, in regards to where Stephanie is located in Eastern North Carolina, the local community college there is Roanoke Chowan Community College. We actually have 58 community colleges across the state of North Carolina. The other component is the on-the-job learning. It's the day-to-day activities that an individual does in that particular occupation, as well as the third component is a progressive wage scale. So as that individual is actually going through the program, going through the classwork related instruction, as well as the work process and the on-the-job learning aspects, their wages should reflect a progression as well. And so at the end of the day, we're going to tell you some good information here shortly, but what it actually does, as Stephanie mentioned earlier, it actually gives you a skilled and certified workforce. Next slide. So what is registered apprenticeship? It's totally employer driven. From day one when I met Stephanie, and the North Carolina Community College System, we wanted to do what she wanted that was best for their organization. So we actually structured the program the way that Roanoke Chowan Health Center actually wanted that program. So it's structured on the job training, the things that an individual or company does on a day-to-day basis. Again, the job-related instruction. The job-related instruction can actually be from a local community college. It can be some online training. It can actually be a combination of both. So it's really whichever way that you actually want to set your program up. Rewards for skill gain. And at the end of the day, when they finish the program, they receive nationally recognized credentials for both the North Carolina Community College System as well as United States Department of Labor. So they're fully trained in that particular occupation. Next slide. So, your question may be, why a registered apprenticeship program? Why registered apprenticeship in general? But what we see is we actually have over 10,000 apprentices here in the state of North Carolina, both private and public sector. But it builds a competitive workforce. It's time and tested. It's a time and tested model. I give the example of when You know, if my dad was an auto mechanic back in the day and I followed him and learned the trade, then I was going through an apprenticeship program. It just wasn't a registered apprenticeship program put on paper. And as I said before, it's also adaptable and flexible, so it can actually be worked out to meet your specific needs. Next slide. Back to you, Stephanie.
So at RCCHC, we partnered with Roanoke Chowan Community College to start a certified medical assistant pathway to transition our CNAs to CMAs. Our CMAs were able to attend class, take the certification exam. We had a small graduation here. We started with 5 CNAs who were able to reduce their hours from, again, 40 hours to 20 hours per week. They attended class on Fridays. And also we had our on-staff clinical instructor, one of our own RNs, who provided the clinical component and also didactic training as well. Here we have one of our graduates who is a CNA now, and she transitioned to and passed the certification exam, and she is a certified medical assistant. So pouring into your own actually goes a long way. Next slide. Here we have our first 3 graduates from the NEMA program. All have completed the course requirements online, the didactic components, and they were able to then complete the clinical components, as we were a clinical entity for NEMA with our own clinical coordinator. Each has passed the CMA certification examination, and they are all working, and we have retained these workers. Next slide. Tony?
So just to tap onto what Stephanie just mentioned, she started out with 4 occupations in the areas of patient CNA, certified medical assistant, patient care, patient account reps, and IT personnel. And so we started out with 4. Now she actually has 12 occupations registered with the North Carolina Community College System Apprenticeship NC. An occupation or a pathway for every occupation within the organization. So as I mentioned earlier, this is a certificate that comes from the North Carolina Community College System saying that that individual has actually completed the registered apprenticeship program with the state of North Carolina. Next slide. This is the certificates or journey worker credentials that you receive from the United States Department of Labor. These are portable credentials, and they're recognized nationally throughout the 50 states. So when each one of those individuals completed that program here at Roanoke Chowan Community Health Center, they received their journey worker certificates. Next slide. So just to tap on before Stephanie comes back on, right now Roanoke Chowan Community Health Center has actually 20 students actually in their registered apprenticeship program. Stephanie?
Those occupations we have registered are certified nursing assistant, pharmacy tech, registered nurse, licensed practical nurse, phlebotomist, information systems. We also have registered in our program, man, Tony, I just blanked out. Wow, certified medical assistant. And in addition, we're adding more occupations. There are over 1,500 occupations you can register as an employer of the apprenticeship program. This picture is of our 4 CNAs that upskilled to CMA, and Kimberly, our instructor. Next slide. So today, with our NEMA program and NC apprenticeship program, fall 2021, we graduated 3 CNAs to transition to CMA. Summer 2021, 6 CNAs to 6 RMAs. 2022, 2 CNAs to 2 CMAs. And we currently have 1 CNA who has completed the NEMA program, and she's studying for her certification exam, and we know she'll do great.
So just to add on to that, Stephanie, you had your certified medical assistant, your medical lab tech, your IT specialist, and we just actually had a IT specialist just graduate this month. You had your patient account rep, your pharmacy tech, your registered nurse, your LPN, your certified nursing assistants, your health information hospital coder, your clinical application specialist, and your medical coder and biller. So those are all the occupations you actually have registered.
Thank you, Tony. We have entered phase 2 of our program, and phase 2 of our NC apprenticeship program is where we are now receiving funding from the federal government, Department of Labor, that has been placed in North Carolina to expand apprenticeship. $12.5 million was placed in North Carolina to expand apprenticeship program. At this point, we have several apprentices who are getting wages also covered, up to $22,000 to $24,000. And so that helps our CCHC continue to expand our program, support our apprenticeships and our apprentices, and also we are able to provide tuition support as well. NEMA program was also recently approved for federal Pell grants, and so our staff are able to apply for FAFSA and receive grant funding to cover their tuition costs. Now, the North Carolina Apprenticeship Program phase 2 approach for us is that we are able to now fully support not only the benefit of wages and also increasing the wages of our apprentices, but also with the wage support from North Carolina, we can continue to allow our staff members to go to school, reduce their weekly time without any use of their vacation time, and also ensure that they are successful in their studies. Thank you so much.
Thank you both so much. And before we just jump into all our panel questions, Stephanie, there was a question specifically for you in the chat for clarification. Do you offer paid time to complete the NEMA program?
Do we offer paid time? We don't reduce our staff members' time. We pay them while they're in class.
Thank you. Awesome. Michelle, can you just stop slide sharing for a minute while we do our panel? Thank you so much. Awesome. And before we dive into our questions, I've gotten this like 5 times throughout the presentation, which just shows how much you all loved it. People are asking for the slides. So those will be uploaded to the Weitzman Education platform at the end of day today. And I'll repeat that, but I just got asked it a few times, so I thought I would address it that way. Perfect. Our first question that we got in was during Sharice and Amy's presentation, but it definitely does relate to Stephanie and Tony as well. The question was, in our experience, the first year for nurse practitioner graduates in the community health setting is a big challenge. Confidence is the #1 challenge, and then just learning how to treat patients with very complicated health situations is the next. Does your program address those things? So I was just wondering if all of you could elaborate on identifying the competencies and how to increase confidence within new graduates and our students.
Yeah, so for the residency particularly, this is sort of exactly why the program was created. And I know Margaret, when she sort of was thinking about the concept of postgraduate training, was new NPs coming to community health, realizing that they had all of this knowledge they attained in their graduate program, but they weren't just seeing diabetes, they weren't just seeing hypertension, they were seeing it in a patient that had multiple coexisting chronic conditions, they had mental health issues, they were facing challenges with access issues around socioeconomic factors, and they weren't seeing it all together, and they had somebody who was able to sort of guide them through all of those pieces. And something else, so confidence is a huge one, competence is the other piece. One of the things that a former resident told me that has just stuck with me for a really long time is that part of his residency was learning to know what he didn't know and to feel comfortable saying, I don't know that and I'm going to look it up, and having really good models that they can look to in our preceptors and our mentors to guide them through the process of building confidence over time. It's not just going to come in that first year. It really takes a while to build to a point of feeling comfortable and confident. So that's sort of the whole ethos of the program, is building confidence in that transitional year. And Amy, I don't know if you want to add anything to that.
Yeah, I would just say that, and I think there's been over time since I've been at Yale, like almost like a culture shift in the mindset of students about residency, and even just the way that we message about it, in the sense that, as was mentioned earlier, at our school, we have a lot of students who are very interested in having careers in community health. And so some of the messaging we have around residency is, this is a great way to enter that. You know, it's like a soft landing where you have additional supports and structure in place for you as you navigate how to take care of complex patients, how to manage, you know, it's just the little things we do every day as a clinician that we take for granted, that when you're a new clinician, that's really hard to do on top of a complex patient profile. So we think that, you know, and we message, and our students understand that residency is oftentimes like a gateway to that career, where it really kind of helps get them the foundational blocks they need to be successful in a career in community health.
The staff I serve are just as vulnerable as many of the patients we serve. And what I know to be true is that the barriers related to wanting to reach an educational goal for my staff include fear. And that fear often was the number one barrier for exploring upskilling or expanded education options. Adult learners have different needs, and mostly we found that confidence was around being able to juggle life and also full-time work. So the decision of RCCHC to take the barriers away from not decreasing time off benefits, paying tuition, and also ensuring benefits stayed in place, healthcare benefits, and allowing a decrease in hours without loss of wages was life-changing, not just for our staff, but for the legacy of the staff members and the families they support. And so confidence is a two-way street. They had the confidence in us to support them through, and now they're more confident to tell other staff members to take the journey.
So adding on to what Stephanie just mentioned, and we talk about, so what the program is actually put in place here at Roanoke Shawan Health Center, a lot of the programs in those occupations are competency-based check. They have actually competency-based checklists to those, right? So they're actually, the supervisor is actually watching that individual on a day-to-day basis and checking off that they're actually competent in those particular skill sets that they want to actually have within the program. So that's been a major game changer in regards to the staff at Roanoke Shawan.
Amazing. Thank you all. On a similar note, someone had asked, what is the time commitment you ask of the students once they graduate? You have invested a lot in them. You know that's definitely a concern of a few people, as you're investing so much time and resources into it. So what is your time commitment to those graduates?
So in the beginning, we required that an agreement be signed for a 2-year time commitment for payment of tuition and wages and benefits. Now that our students are eligible for Pell Grant through the NEMA program, we no longer have that type of agreement in place. Now, for the apprenticeship program, our students get full tuition funding and also some wage replacement to support RCCHC. We're reconsidering what types of agreements that we may need to put in place. To date, none of our apprenticeship students have transitioned away. We've retained all. And what we found is that putting the agreement in place became a barrier. Folks didn't want to sign a 2-year agreement. We removed that. And so those negative thoughts around what an agreement means have gone away.
So I've actually been in, like I said, in this position for the last 18 years in regards to registered apprenticeship. And one of the main things that you actually see when we put together a registered apprenticeship program is the retention. And number one, the retention is really high because those individual employees on your staff see that you're actually investing in them. So they're more apt to stay with the organization longer.
An apprenticeship also, you must increase the apprentice wages in a standard method and time. And so they know they're going to get wage increases. And so that's built into the program. And so it also helps to retain the staff members.
Sharice or Amy, do you have anything else to add regarding time? Sharice, you probably.
I mean, ours is a little bit different, I think, but we do a 2-year agreement, and mostly it's around commitment to doing the residency. And it's been pretty standard for postgraduate training programs, especially because these are full-time providers, to transition to formal agreements and doing 2-year commitments. We went to 2-year commitments probably 6 or 7 years ago. And I was a little concerned that people wouldn't want to sign the 2-year agreement, but the feedback we've gotten from people is that having that consistency of practice for them and having that job kind of baked into the second year has been really helpful. They're not spending the middle of their residency worrying about finding their next position, and they have, most of our residents end up staying at the site that they train, so they have that built-in support network that they've developed, which as a new provider outside of the residency has become really important for them as well. They're not having to learn new systems. And so that's been really helpful, I think, for our program to have that built in from our end. And I think for a return on investment, especially for any program, so these are big investments for organizations to take on. You know, we have this consistent pipeline of providers who are trained in the communities and staying in those communities for retention purposes. It has worked really well.
Thank you. And some people might not even have these partnerships. So I'm really just wondering, could you elaborate more on the history of getting these conversations started? I know you touched on it a bit, both of you, at the beginning of your presentations, but how do you get those conversations started, both from a health center side of wanting to take students, but then from the academic partnership side of wanting to give students clinical placements and forming that partnership?
I mean, I could start. I think that the concept of academic partnerships is a pretty hot topic in nurse practitioner education right now, because we recognize that there is a lot of value added in a bi-directional way. And with the increase in clinical hours required for NP programs, this becomes even more highlighted. So I think that CHC was kind of a natural fit for us because we were already sending students to the site, and we already had faculty that were working at this site. So it was somewhat natural for us to kind of look to them. They're one of the biggest community health centers in our state. So I think that was kind of why, you know, outside of the fact that we had this grant that kind of solidified it, but they've always kind of been, as we mentioned, an informal partnership. So, you know, I think my recommendation as from the faculty side is really just to look at who are our students interfacing with regularly and who we're teaching our students in a clinical landscape, and how can we solidify those relationships a little better.
And I think, I know Amy and I talked a lot about this, and with the other presenters as well, is that I think it works best when people are coming at it from these mutually beneficial situations of wanting to support communities and workforce, and we're all invested in this work. And so finding like-minded organizations and partners in that, you know, having people who are out in the communities who are understanding what the challenges are that the workforce is facing and how we can come up with creative solutions to solve those, I think is really where it starts. It has to be a two-way street. I think anybody coming at it from a one-way street just doesn't work that well. So making sure that you have sort of that mutually shared, I think, mission and values is really important.
So true. Tony has been a wonderful partner, and he has been an awesome facilitator of those conversations with the community college system. In North Carolina, students can apply and be accepted and complete online courses at any of the community colleges across the state. And so you don't have to limit access. Our IT student currently completed the IT program down the street at the Roanoke Chowan Community College. She's now interested in health information systems, as she would like to complete a bachelor's degree. And so now she's attending Pitt County Community College, which is an hour and 15 minutes away from us, but we give her the time, we give her support with reimbursement for her gas, and so that she is able to complete the program. And so those conversations are important, in that our community college locally was having some struggles as well. And so it is a two-way street. By having this program, it also improves their situation in terms of expanding the student population.
Awesome. And there's one last question in the chat, but if anyone else has questions, I really encourage you to put it in the chat. Charisse, did you see it already?
I did,
Okay,
yeah,
perfect.
thank
Go
you.
for it.
Yeah, it's a really good question. So there's a number of loan repayment programs. They all have, there's different versions of them. So there's the National NHSC, the National Health Service Corps program scholars. Those are people who commit upfront to service-oriented placements after they graduate. They are not eligible in the residency year, but they are eligible in the year after. Then there is the Nurse Corps Scholars Program, and they are eligible for the residency year, which is great. We love that. And so it's a 2-year commitment, but they get to count the residency year in the second year. And then there's just NHSC loan repayment, which is what you apply to once you're in practice. And so I think residents apply during the residency year to get the next year counted. And there's a third one we just learned about, and I'm totally blanking. It's NHSC, it's not scholars, it's somewhere in between, but graduates can they can apply for it and get accepted in their final year. And it just has a lower threshold for the HRSA score, but they still are placed at a high need site. So there's all these loan repayment options for people, which is such a great resource. You know, we've talked to making sure that graduate students know about these and know about the opportunity, because they really are great opportunities for our students who have really big loan repayments, and to move them and get interested in service-based obligations after their graduate programs.
So I just want to tap on in regards to here in North Carolina, and Stephanie and I are actually working on this concept right now, actually recruiting high school students. We're working with a lot of the local high schools to actually recruit high school students. Back in 2017, the North Carolina legislature said that if you had a high school junior or senior that was either in a registered apprenticeship program or a pre-apprenticeship program prior to high school graduation, then their tuition at the local community college would be waived. So that equates to an associate's degree straight out of high school. What we've learned is that not all individuals actually want or can afford to go to a 4-year college or university. So we're using this as a leveraging tool to actually get those individuals that want to be in a registered apprenticeship program into the workforce.
There's one more question for Tony.
Tony, I'm not sure if you see it in the chat, but someone had a question for you specifically. Do you only work on healthcare apprenticeships?
No, so we actually here in North Carolina, like I said, Stephanie, you know, there's over 1,000 occupations that are actually apprenticeable. We're actually governed by the United States Department of Labor again, but we have advanced manufacturing, we have public health and safety, we have office administration, we have, you know, like I said, we have 10,000 apprentices here in the state of North Carolina. So healthcare is one of the ones that we're really focusing on right now. Stephanie's program is one of the leaders in the state. We actually are working with University of North Carolina as well as Duke University to do some of the things that Stephanie's already done. And we're working with UNC on their surgical technicians as well, because that's an occupation that they're really in need for, as well as their pharmacy technicians. and as well as their registered nurses. So registered nurses across the state they actually have a statewide program. So to answer your question, there's over all the occupation. If you think about it pretty much, then we can register your program or your occupation.
Amazing, thank you. We have about 2 more minutes left. Do we have any other final thoughts from any of our amazing panelists? Any final questions? Perfect. Well, thank you all for being here and for sharing your expertise and your experience. It was really wonderful to hear from all of you and your efforts to support training the next generation. Oh, and Cheryl, Stephanie will be reaching out to you. Awesome.
Thank you.
I'm going to pass it off to Helen, who's going to be leading our next session.
Thank you so much, Megan, and thank you to all the speakers on that panel. Really fascinating and yeah, important stuff going on in those different states. So for our next session, we'll be doing a Health Center Spotlight with Courtney McAuliffe, and I'll do a little intro to Courtney and then pass it off to her. So Courtney is the VP of Human Resources at Open Door Health Services in Muncie, Indiana, a not-for-profit federally qualified health center, or FQHC, that acts as a safety net for the uninsured and underinsured of East Central Indiana. McAuliffe received her bachelor's degree in interpersonal communication and sociology from Central Michigan University. Before joining Open Door, she gained 12 years of experience in the restaurant and hospitality industry, 5 years of restaurant operations experience, and 8 years of recruitment, development, and HR experience. So because of her extensive background in the HR field, Courtney has a great understanding of the development and implementation of HR policies and procedures, and brings a lot of knowledge to her position. So with all that information, I'm so excited to hear from you, Courtney, and hear about all the wonderful things that y'all are doing at Open Door Health Services, and I'll pass it off to you.
Awesome. Thank you. Thank you so much. Can everybody hear me okay? Okay, perfect. I'm very excited to talk about what we are doing at Open Door. I will also say before we jump in, I am fortunate to be the spokesperson for these programs and for these great endeavors, but we have a crew of team that are working in multiple facets in order to make this successful. And one of the areas that we really wanted to highlight would be focusing on our inclusivity, our sense of belonging, but also our overall employee engagement and well-being. And if you want to go to the next slide. So yes, they shared a wonderful bio about me, but my passion is really in creating a sense of belonging for team members. And that looks very different depending on where you are or what level you are, or even within the organization, it looks a little bit differently. And so I am excited to be able to talk about that passion today, but I also am excited to talk a little bit about Open Door and some of the really great work that we are doing in the sense of belonging and understanding of our team members. So you can go to the next slide. And I think anytime you're thinking about trying to understand a sense of belonging for your team members or employee appreciation, or however that program might look like for your world, I always pause in the start of like, where do we even begin? Because, you might have really great programs in place and you're doing a lot of work and a lot of effort. And then there's always maybe a couple people that aren't connecting with that effort, or the scope of the environment changes, the scope of the workforce changes, who you're hiring changes. And so then it feels like you're kind of way back to the starting line. So as you are approaching your sense of belonging or your inclusivity program or engagement programs, you want to make sure that you take time to pause, take time to process where you want to go, take time to understand where you currently are, and then also think about kind of where you see yourself in 1 year, 3 years, 5 years. I think sometimes when we start these programs, and we also have had to learn the hard way from time to time, when you start programs like this or try to evolve programs like the ones we're going to talk about, we sometimes want to get to the end faster, and we cut out some of those middle steps that are really important to the success. So where we started was connecting with an external understanding. We knew who we thought we were inside our four walls, but we also know that we're only as good as our employees might realize us, our future employees might know who we are, our future patients, our future contacts, and our community partners. So we started first with meeting with 4 different community partners. Some were board members, some were community partners of other nonprofits, some were patients, and we asked them these questions. How are we doing? What do people in the community who used our services think of our experience? What are the community needs that are being met? And maybe they're being met by Open Door, or maybe they're being met by a counterpart in our community that we might be able to partner with. We also asked them about advice and suggestions that they may have on leading programs like inclusivity, diversity, sense of belonging, employee engagement. What have they seen previously that worked, and what have they seen previously that didn't work? We started this process, I would say, December of 2019, January of 2020 is really where this process started for us. And that's when these conversations happened. We focused on things not only from an Open Door as a health center, but we asked questions about us as a community partner, as an employer, as community leaders, so that we could make sure we had an understanding of all facets of where we saw ourselves as a community player. From that step, we then went to, and you'd be able to go to the next slide if you don't mind, we created 2 different programs to better support and better connect with our community partners and our community agents. So the first is a program that we are calling our Community Connections Team. This is individuals that are in our community. So they do not have desks at our Open Door location, but they are working in and out of our community areas. So they might be helping at a food pantry on one day. They might be participating in a weekly neighborhood dinner that takes place. They may be setting up a table at our community library or at our schools, or anywhere that there might be an ability to have a table and a chair, 2 chairs, if at all possible, so that we are able to engage with community members. We focused on neighborhoods where there were high barriers to health, maybe a lower propensity to seek healthcare, but in areas that had high needs of resources. The director of this department has a really great way of phrasing our community, in that we have a lot of resources. We just need to make sure that we're getting them into the hands of the individuals that need them. But in order to do that, we had to build relationships. And so we started with the relationships. In our first few months and quarters of that, we tracked how many contacts we had. Then we were finally able to start tracking how many contacts turned into patient appointments. We hope those patient appointments are with us, but there are a multitude of services within our community, and we know we are only as healthy as our community is healthy. And so as long as they're seeking care, we want to support wherever that care is. The second thing we did based on external understanding did happen a little bit more inside the traditional 4 walls, and that was creating a patient advocate coordinator. Essentially, this person is somebody that handles patient feedback, patient concerns, patient complaints. It may come in through a patient portal. It may come in through feedback directly through team members that route to this individual. It may come in through still connecting with community partners and following up on concerns. We were really particular about the name that we utilized. We could have absolutely titled this, customer service, patient service. We could have titled it patient feedback, but the word advocate was really important to us when we were creating this position. And that's because for 2 reasons. The first, we wanted patients to know that they can advocate for themselves. We wanted them to know that they had somebody that was in their corner, whether they thought all of us were in their corner or not. We wanted to make sure that patients then were also learning how to advocate for themselves and how to speak up about concerns, highlight what aspects of care is really important to them. The second reason that we wanted to make sure that we use that word advocate is because we wanted to ensure that this position was able to enact change. And so this person helps monitor solutions to those concerns, help monitors the trends of those concerns, helps highlight, gosh, this is now becoming a trend, and really just helps to maintain kind of the forward motion of those concerns, ensuring that they are moving forward and that we're resolving those concerns. So those were the two areas that we started working externally, but then we brought a focus more internally. This also happened at kind of start of 2020. Annually, we do an employee engagement survey. We had been doing that for the last a decade, to my knowledge. And we focused, the start of 2020, we focused more on where were we from a baseline of belonging, inclusivity, connection to our mission, vision, and values. When I said that we like to improve the quality of life of others, does our brand new team member know what that means? Does our tenured team member know what that means? And do they see that goal as we are making decisions, expansions, hiring, onboarding, at every step of their day-to-day? So this survey got us a baseline. In that same survey, we did a call out where we asked for people that wanted to participate in creating an inclusivity program, in creating a sense of belonging program. We wanted it to be completely voluntary. We wanted this initial start to have, a very little amount of a vetting process, because we wanted to make sure we were hearing all ranges of voices. We shared very directly what the feedback was from our community partners. In that feedback that we got from our community partners, we did have hourly team members there. We had providers there. We had directors and managers there. So it was not just our executive team that were getting that feedback. And then we utilized those same individuals that were part of that community partner outreach to share that feedback, so that our team knew it was not diluted feedback. We were bringing this directly, or as directly as we could, to them. And we weren't changing the feedback from the good, the bad, to the in-between. We asked that team to really start to assess, okay, if we're going to really dig in on this and have a successful program, what does this initial startup need to look like? What does the first year, second year, third year need to look like? At that same time, we also created a position within the HR team that was our inclusion and engagement coordinator. So this person focuses on inclusion, they focus on our sense of belonging, and they handle all of our engagement with our team members. So they're really a face for our team members, regardless of position, department, location, of somebody that they can go to that's just a resource, a sounding board, and helps ensure that we're highlighting the really great work that our team is doing. And so once we did that call out to ask who wanted for help, then we really started to dig in on what that first year was going to look like. And so if you want to go to the next slide. The first year that they wanted us to do is do an overhaul of policy and procedures. This started at a very basic level. We were not looking to tackle every single policy we had in that first year, but we wanted to make sure that we were creating a group of things that we were looking at when we were reviewing policy and procedures. Do we have gender pronouns in there? And if so, is it possible to remove it? So some of our clinical approaches, maybe there's a reason why that gender pronoun needs to be there. If there's not a reason, it was removed. Were we looking at policies in a way that brought in different perspectives from socioeconomic, gender, race, ethnicity in mind? And in order to understand that, we shared those policies and procedures with departments that weren't interacting with those procedures. So we gave a stack of HR policies to individuals that are on our clinical floor that said, what questions do you have? What would you change? What don't you understand? And then we compared some of those policy and procedures with the feedback that our community partners had. So one of the feedback was, sometimes the patients didn't feel that we understood when there were struggles keeping them from an appointment, or struggles that made them maybe late for an appointment. So we took a look at our procedure that was, was our no-show procedure. We need to have one. We need to make sure we're protecting the organization, but we need to make sure that procedure had a framework that was compassionate to the issues that may have caused that individual to be late for their employment. We then also took that original kind of deeper dive survey and we tried to dig even deeper. So we took specific scenarios and feedback that they provided us and asked the what, the how, the when, what could you change? How would you change it? What does this need to look like? These surveys are still anonymous, so we wanted to make sure we were still encouraging participation, but we needed to have more specific knowledge. We couldn't just understand we couldn't hear a phrase that said, oh, your PTO policy, and not understand what about the PTO policy might be slightly hindering or might be slightly restrictive. And so we asked them some follow-up questions for that. We then also created a list of training and support needs. So when you hear the word diversity, what do you know? What do you not know? When you hear the word inclusion, what do you know? What do you not know? What concerns do you have when tackling these topics in a workplace? And so we looked at those training support needs, not only from our team of volunteers who were willing to tackle this initiative with us, but we looked at it for what do new team members joining the organization need to know? What do our managers need to know in order to support this type of evolution within our organization? What do our senior leaders need to know in order to make sure that this continues to stay successful? So in that first year, it was really fact-finding, list generating, and creating the goals and almost our own strategic plan. I will highlight here, it felt like a slow process, and we got some of that feedback. Our rationale came directly from our community partners that had shared situations where programs had not done well in this. And that was that they moved too quickly. They didn't get a good foundation. They didn't have a solid understanding of where they wanted to go. It was really a box to check off, but not willing to kind of dig in and do the work. And so we took that first year very seriously around digging in and doing that work. Next slide, please. So in year 2 is where we started to then kind of develop how were we going to execute these tasks. And so the first is we developed a more robust and concrete task team. And they helped us create and maintain that foundation. We asked that task team what DEI means to them. They developed the name, the Jedi Council. I know other organizations use this, but how we came to wanting to land on Jedi as opposed to only focusing on DEI, using phrasing like belonging, is because we asked them to use words that described inclusivity, that described diversity, described equity. And so really, it came following the same justice, equity. I love the Jedi model too, absolutely. Diversity and inclusion. And so I think what was really interesting to hear from my task team is that they felt empowered to demand justice. And that was really important to make sure that this team knew that if I was missing the mark, if other senior leaders were missing the mark, that they would then say, nope, Courtney, you missed the mark. Here's what we need to do to fix it. And so we wanted to make sure that justice was included in our approach to this council. We developed a team charter for them, how to operate, I'm so sorry, I'm embarrassed to spell the word focus wrong, so I'm so sorry. How we were going to focus on our meetings, our discussions, how we were going to operate, how we were going to call in and call out each other, and then how are we going to bring it outside our team meetings. We decided we wanted to follow a similar rotation to Robert's Rules of Order. So if you are on boards, you probably are familiar with this, where we would take it to a vote. We would seek a team rotation. So if there were people that were on the task team a little bit too long, we would want to make sure that we were rotating them off so that we could continue to get fresh perspectives, fresh ideas, fresh understanding. We then also developed a nominating process for new task team members. And we wanted to look for a variety of ways of representation. So I listed some here, definitely not limited to that. Accessibility, gender, position levels, department or work location, race, ethnicity, educational background, socioeconomic background. So people that had a different perspective, but also could highlight things that were happening in various departments, various levels, and various workplaces. So next screen, please. They then also brought training into the Jedi Council. So this training was done sometimes by internal experts that we had, but we also are very fortunate in Delaware County and Indiana that we have Ball State University right in our backyard. We also have a couple nonprofit entities that focus on training and development and cultivating company culture. And so we utilized our local experts so that we could make sure we were getting an additional voice here in our organization to make sure that we were creating spaces where we could ask questions, get perspectives, and gain understanding. But we did also want to utilize our internal expertise as well. So we did trainings for the Jedi Council of understanding accessibility. How do you look at it? What do you look at? How do you know, what should be accessible and not accessible? We did a queer 101. What's the terminology? What do certain things mean? How do you ask certain questions? How do you create a sense of understanding? Because we felt that our team had shared that they knew these terminologies were out there, but they didn't feel comfortable having conversations using them, not to patients, not to team members, not to community members. We did some training on workplace allyship, calling in, calling out, providing feedback, and our focus on that is using Kim Scott's Radical Candor. So if you have not read that book, I do encourage it. It is talking about challenging individuals, but with a sense of relationship and from a place of care. So we do that throughout our organization so that people understand that when we do challenge, it's because we want to make people better. It's not because we want to challenge and point out where things aren't going well. The goal of the trainings was to develop a comfort discussing those sensitive topics. We know, especially in the workplace, when you start to hear the conversation veer towards a level of diversity, inclusion, people tend to back away because they're nervous. They don't want to say the wrong thing. Or sometimes folks that maybe should kind of pause and listen don't know how to do so. They just fill the void that they think is there. And so we wanted to create an understanding of how to have those conversations. Another community partner that we partnered with here was United Way locally. They do our local United Way chapter is wonderful, and they do a fantastic equity challenge every year where they highlight a variety of TED Talks, books, articles. And so we partnered with them to make sure that we were looking at the right resources and guidelines. And then we challenged our Jedi Council to bring this to their teams. What were they learning in our meetings? How could they highlight it in their teams? And how could they utilize what they were learning to make their teams stronger? Next slide, please. And then our year 3 initiative, which is this year right now for us, it's bringing it outside the council. So, and we have gotten this feedback too. So I want to highlight areas that we were missing the mark, and we maybe spent a little bit too much time on year 2, not overlapping year 2 to then bring it outside the council. And so I wish we would have blended year 2 and 3 a little bit. But we reorganized our orientation and our onboarding process. We wanted to make sure that our philosophy on inclusion, belonging, and understanding started right on day 1 of employment. It was already written into our mission statements, and so it was already part of our hiring process, but we wanted to make sure that people understood how it lived in our organization on day 1. We did additional employee engagement surveys. We wanted to ask, and we did this through a third party. Now that we had internal Jedi Council, we wanted to make sure we were doing this through a third party. So we partnered with Ball State, and they asked questions of, what do people know about Jedi? What do people know about our internal council? How do they hear us talk about it? When do they hear us talk about it? When do they not hear us talk about it, but they want to? Is it discussed in department meetings? Do they see leadership really walking that walk? And do they see decisions being made with Jedi in mind? And we were a little bit in the middle of the road here. They highlighted some areas that we can absolutely bring to life the great work that our council is doing. They highlighted some initiatives that they felt that they wanted our senior leadership to take. Some of that was being visible to make sure we understood everything that was happening within our departments. Some of it was making sure that we had a clear kind of taking that Jedi charter that they had started to hear about and really bring it into our other departments and bring it into our organization as a whole. So we're all committed to the same level of understanding when it comes to inclusivity. And then next slide. We also revisited our employee policies. So we started this on year 1. Now that we've learned some things, we wanted to do it again on year 3. So we did an overhaul of our PTO. It just launched today. It was highlighted today. It goes live in our new fiscal year of July 1. We looked at our bereavement programs. Did that really include the variety of types of families we have working within our organization? We looked at our well-being activities, our uniform guidelines. We looked at remote and flexible schedule. We created a program that we call our department engagement funds. So we put money right into the hands of our department leaders to have funds that they can use how it makes sense to celebrate the uniqueness and the exciting things that are happening on their teams. That way they're not waiting for somebody like me sitting in an office to highlight that for them, but they were hearing it directly from the source where that excitement is happening. And as an organization, and this happened a little bit in year 2, but we continue it in year 3 and beyond, is we as an organization made a commitment to paying a living wage. And we are committed to advocating for that as we are outside our 4 walls as well, because it's important not only to our team members, but it's also important to those living in our communities from what we're hearing for our community partnerships that we have. We have expanded our recruitment focus. So we also hired an additional person to join our HR team that is going to focus on how do we have a diversity in who we're onboarding. Are we at the right job fairs? Are we connecting with the right community partners when it comes to employment opportunities and connections? And how comfortable are we making it for individuals that want to apply or are hesitant about applying? Do we have enough representation that is available to be a resource for our onboarding or recruiting applicants? We've also made sure to streamline our meeting and agenda templates and topics. We want to make sure that the information happening not only in our JEDI task team and council, but in all of our councils and task teams and kind of breakouts, that they're being highlighted and updated in our departments. But then also those highlights from our departments are being routed then back to our leadership meetings as well. So those meeting agendas and topics, we wanted to create in a way that it was a two-way street between all of the types of meetings. And then next slide. Part of our feedback in year 2, and also a little bit of a focus on year 3, was our well-being program. Previously known as a wellness program, but based on feedback, we also wanted to change the name to well-being. We wanted the focus to be on whole person, not just on activity and not just on physical attributes to wellness. This is our approach to patient care. We want to focus on the whole person. And so we wanted to bring that focus to our team members as well to make sure they were focusing on their whole person. So we created the 4 pillars of well-being that were important to our team. We got these pillars based on feedback that came from an employee engagement survey. They wanted to focus on mental health. They wanted to focus on physical health. They wanted to focus on financial health and well-being. And they wanted to focus on what we call it as social. And social was a combination of community, spiritual, and then some use the word social. We then focused on what types of activities could we do to really pull all 4 of these pillars out into our organization. So 1 month we focus on our 401k, we focus on financial availability, financial understanding, savings, even if it's only $5, how that adds up. We do a financial kind of literacy program so that we would be able to tackle that. And then we do things like having volunteer opportunities, again, partnered with United Way, partner with our school systems. We bring blood donation drives into our organization. And we do some physical challenges as well. We have a water challenge, we have a step challenge, we have a few other challenges, but we do those larger challenges quarterly, focusing then on some of the other pillars in those off months that we're not doing those challenges. We have reimbursement opportunities based on well-being. And so they're able to submit that and then get some reimbursement throughout the year. And most of these activities, if not all of them, function while on the clock and getting paid time. So we make sure that we free up opportunities for them day to day for them to participate in this. And then next question, or next slide, please. And then so our continued goals, again, because this is an ever evolving process and program, is that we will continue to survey, regroup, and realign. We do a little bit of realignment every new wave of task team members. And so half of our task team fall off every year. And so every year we have a little bit of overlap between people from previous year. We do our employee engagement survey every year, and then we dig in deeper following that survey based on the feedback that was uniquely identified. And then we're really working on creating additional open door programming. So some of the things that we'll be rolling out a little bit later this year, start of next year, but as a focus in this next fiscal year, is creating the development paths for our team members, but also creating an understanding of what development looks like. I think often we create these paths and we expect people to know what these stepping stones would be, because in our worlds of, or in my world of HR, those stepping stones are in every aspect of what I focus on. But for an individual that came from maybe a household or a previous career that did not have a stepping stone, how do we create an understanding of what growth looks like, what growth can be, and how do they know what those growth opportunities are? We'll be bringing some of those trainings that we did for our Jedi Council into our departments, and we've already started that this year. We did a trauma-informed care training with our teams. We did a patient service and kind of a customer service training with our team that brought in feedback that we had been getting from our community partners. And then our next wave would be revisiting how to do some of that call in, call out, that radical candor of challenging from a place of care, and then also continuing to look at our policies, our procedures, and making sure that we're connecting with the evolution of not only our work team and our organization, but our community partners. So sorry, I shared a lot of information because I love these programs. And again, I'm just the fortunate one that gets to highlight them. I am not the one that is executing a lot of these day-to-day tasks. That is done from a lot of internal experts that we have, but I would love to open the floor, what questions you might have, what things you're doing in your organizations that I could learn from or that we could share with each other. But I would love to open the floor, however that best works with our facilitators.
Great. Thank you so much, Courtney, for sharing all that's going on at Open Door Health Services around all of this. You're doing some amazing work, so we're so excited. Like Courtney said, if you have questions, please put them in the chat. I'll read them out loud. But yeah, we'd love to hear what your questions are. One first easy question is, what's the name of the Kim Scott book you mentioned?
Yeah, so it's Radical Candor. Kim Scott also has a really robust webpage. So if you Google Kim Scott, you would get there, and she's done some TED Talks. She's had some articles listed, and she continues to evolve kind of what her grid looks like for Radical Candor. And the idea behind her approach, like I had shared earlier, was creating a sense of care, and that's why we're providing that challenge or that feedback. And so I think a lot of times we tend to shy away from giving feedback or shy away from highlighting, gosh, that maybe didn't go as well as we had wanted, because we're worried about hurting other people's feelings. But what Kim Scott highlights is that we're actually being a detriment to that individual by not sharing that feedback, because they're not able to then improve on themselves. They're not able to get a little bit better themselves. And we're just showing that we're allowing that type of behavior or action to continue. So I appreciate her approach.
Yeah, absolutely. Thank you for sharing. So our next question is, first, thank you so much for expanding your bereavement policy as a comment. And then how do you speak with leadership or other organizations about the fundamental importance of this, as family looks so different for everyone, yet many places see it narrowly or make those assumptions about what immediate family means to folks?
Yeah, that's a great question. And it takes it takes continued conversations. And so the first thing we did put in our bereavement policy is that we normally that would maybe happen and our health center, so this might look different for all of you, but our health center is about 250 people. So we're still on the smaller side. So we're able to do this still at this point of the game, but we route all of that directly to HR so that HR is able to have those conversations. So first, those conversations are happening with us. And then we share the conversation with leadership as to the why we're allowing some of that. We share in our change of the policy. So when we changed that, we explained some of the different views of families. We tried to utilize examples that were slightly more common examples of the non-traditional nuclear family, so that hopefully that resonated with individuals that were that maybe were used to a pretty standard immediate family only policy, because they could say, oh gosh, no, I did grow up with my cousin. I absolutely would want to be off work for that, should anything happen to them. And then it's really a case by case basis to help managers understand that. From a senior leadership standpoint, though, I am really lucky and I got zero pushback when we tried to push that out. So I'm very fortunate to that. And I know that others have an uphill battle in both directions sometimes.
Yeah, that's awesome. So our next question is, what moved you in early 2020 to begin this work, and whether you're encountering any Jedi fatigue, and if so, how are you addressing that?
Yeah, great question. So we started this process, honestly. I had a team member that was on my HR team. She was an office coordinator, and she came to me and said, hey, there's areas of opportunity from understanding like inclusivity in our organization. And so her and I had a lot of conversations about it. And that's when we said, okay, we started thinking maybe more on a little bit of a smaller scale, but how do we start to have awareness around important topics, awareness around being an inclusive environment. We also started to have a commitment from our recruiting standpoint to make sure that we were bringing individuals in that were a representation of the patients that we served. So it is our goal as the organization to always be slightly more diverse or have more representation than what is listed on kind of the census reports, if you will, that is produced in our organization. So we want to be better than that. And so that's what caused us to start that at end of 2019, 2020. I do think our team are getting a little bit of a fatigue. And sometimes I'm hearing, oh, it's HR, like that they have to care about this type of thing. And I think one, we handle that on a case by case basis when people are maybe rejecting the idea of inclusivity or understanding. We have needed to terminate individuals that did not uphold our understanding or our commitment to that. And it wasn't an easy decision, but we wanted to protect what we were building and protect the mission, vision, and values of our organization. And I think that rotation of our Jedi Council is really important. So it may be still funneling under the HR department, but there are multiple voices that are constantly coming on to our Jedi Council. So there's new focus, there's new wave of excitement, there's new energy that's coming on. And I think that has been imperative to our ability to maintain it. Otherwise, I do think, Jared, there would have been a risk of it kind of fizzling out or it seeming like a box we were checking off, but we have built it into our continued culture and expansion.
I think that's so critical, especially because we know that like this is the work of a lifetime. None of us will ever be done learning and unlearning in this space. So yeah, I really commend you on having woven it in, as you've said, and like you said, like rotating people in and out so that they can like come to it with that fresh energy. Because as much as it is a project of a lifetime, it is also exhausting, as we know. So yeah, I really appreciate that. We have a comment in the chat about focusing on DEIB, so diversity, equity, inclusion, and belonging as they get underway, that element of belonging being so important. So thank you so much for sharing that with us. And then another comment / question is that I work to implement similar as a queer identified clinician, LCSW, working with marginalized youth and families and cultural liaison in an FQHC. Sorry, my cat. It's an hour and a half from first dinner time, and so now's the time that I get bothered. Anyway,
They're alerting you. Yes.
Yeah. So the question is how to engage leadership to listen, not merely hear. Examples in the policy language using he, she, or team building activities across the agency, which encourage competition around kudos rather than value. Any data? Do you have any digestible research? It's, it was a big question, but yeah, essentially, how are you engaging those leaders to listen and not just hear?
Yeah, absolutely. If you'd be willing to put your email in the chat, or I'm happy to share this with our sponsors. We have a couple things that we utilized. My HR coordinator, as she was getting her master's, did focus particularly on queer understanding, and so shared some training to providers of our organizations, and her perspective of that training was to help our providers understand the patients that were coming in, but she also did that training to all of our leadership too. And so I'm happy to share some of that feedback. I am not as well versed in that area, so I don't feel comfortable sharing her specific data or research sources, but I'm happy to share that out if that's something that we would be able to get out to the group.
Yeah, for sure. It looks like folks are putting their email in the chat, but we can also make sure to do that connecting piece afterwards.
Perfect. Thanks, Helen. And then in terms of just utilizing pronouns, I mean, that is something that we started. We were very deliberate and vocal about the removal of those in our policies and procedures. As an organization, we also sponsor our local pride event that happens, and that was an area that we encourage. So we sponsor a couple of things that were really important to our local community, and so that's our Juneteenth event that happens. We also added that in as a date for a paid holiday, and then our Pride, which for us it happens in September. It's when our students come back from campus, and so we wanted to make sure that we were an active role in both of those events locally from a planning standpoint, a sponsorship standpoint, and to just kind of reiterate our commitment to making sure that we were a welcoming and inclusive and belonging environment.
That's fantastic. I think it also shows, again, like you talked about at the beginning of your presentation, that you're creating these connections across your community, and that like you can't have the J part of JEDI without doing that interaction and like the action part of being in your community. So I really appreciate both those connections that you're making in terms of in terms of the services and connecting patients to different services, but also in terms of saying like, we are a partner in this community and we're going to show up for these important events.
Yeah, absolutely. So our mission is that we want to improve the quality of life for others. And that's really the sentence. We extend it to explain that it's where we work, where we live, where we play. You know, we can absolutely do everything we can to make sure that we have the point of care testing, that we follow up on labs, that we do our checklist inside the patient four walls, but we know that is a small aspect of what makes somebody a healthy individual. And it's that justice part, that advocacy part, that's really important to our team members and to our organization to make sure that it's not only happening in our four walls, but it's happening in our communities as a whole.
Yes, absolutely. I love that. And it gets at that like moral distress, moral injury piece of like not necessarily feeling like we can do everything that we want to be doing for our patients, our communities. And so your organization showing that you care about, again, like you said, whole people, both as employees and as patients, I think is really powerful.
Yeah.
So there's one more question that's sort of, logistical, but do paid days offer employees include both MLK Day and Juneteenth or just Juneteenth?
That's a great question. For us, it's just Juneteenth and then 4th of July. And our philosophy was that those were the two Independence Days of our country. And so we wanted to make sure that we were celebrating both. We do also have, though, for every employee, one float holiday that they get every calendar year. We know that we're closed on some traditional federal holidays, but that might not encompass all of the important holidays to our team members. And so we wanted to make sure that they had one day that was separate from vacation, that they would be able to utilize to celebrate any day that's important to them. And so some may be MLK Day, Veterans Day, Flag Day is an example that I always throw out for folks when explaining it. So, but anything that was important to individuals to make sure that they could celebrate with their loved ones.
That's awesome. Yeah, I love having that flexibility available to folks. All right, I don't see any more questions in the chat. Thank you so much, Courtney, for joining us and for sharing this really wonderful information about all the things that you all are doing at Open Door Services. I learned a lot, and I assume everyone else did as well. So thank you again.
Thank you.
And with that, I will pass it off to Suzanne Spear to do our closeout for the first day of the summit. Suzanne, you're muted.
And I keep doing that, double muting myself. So much good content. Thank you so much, Courtney, for a tremendous presentation and sharing with all of us about the amazing things you're doing at your health center, and to Helen for moderating this session. Also want to thank every single person who has presented today, spoken and shared and moderated and all that. What an amazing, amazing day we have had. So to that end, we're going to do a little bit of a closeout. So we are going to go back to the same Mentimeter that we have been using for prior times. So feel free to use that QR code that Megan just put up there, or go to menti.com and enter 25991916 and enter just one key takeaway. Use one word. We're going to do another word cloud. So one word, with your impression or thoughts about today, or a key takeaway there. Megan, thank you again for putting that in the chat there. What comes to mind when you think about everything that you heard today? So we started the day with federal partners. Then we talked about a Be Well Together initiative. Then we talked about partners and pathways panel. And then obviously we just opened door for our health center spotlight. So what comes to mind there?
Awesome. And I see that 67 people have joined us, and that number keeps going up. So I'm going to go ahead and advance to our word cloud. And again, the link for that is in the chat if you didn't get it. I'm also going to go ahead and download this PDF at the end of today's session and upload it to the Weitzman Education platform, so everyone can see it and have it to access. I know so many of you added such great points about the breakout groups. So thank you for that.
Awesome. Great. Thank you for that reminder, Megan. All right, so we've got some words coming in. Partnership, opportunity, apprenticeship, informative, engaging, hope. Love that, hope. You always got to have hope. Possible, growth, opportunity. I think I said inspiring. And as we, watch all of the different words in the word cloud come up, these two are emerging that are really rising to the top as some that are coming out, a little bit more than others, and that those two are informative and engaging. And I couldn't agree more. So much good information that has come today. Wow, what a great day, and inspiring too. Wonderful. I love it. Forward thinking. Yes, absolutely. What are some others? Sorry, as I lean to read the word cloud here. Integrity, belonging, humbled. Yes, absolutely. Well, awesome. Well, thank you guys so much for, really being a part and engaging in the word cloud. It's always fun to see what people are thinking and doing. So as we wrap up our session today, we have 3 things that we would like you to do. So first of all, we would like you to take the evaluation that is going to pop up in Zoom here right now. Thank you, Megan, or whomever pushed that out. Please take that evaluation. We appreciate your feedback. BIPIC and HRSA appreciate your feedback. And so if you could do that before you leave today, that would be great. Second of all, please complete the session evaluations in the Weitzman platform where you registered. That will allow you to attain your CE credit. So if that's important to you and that's something that you would like to have as for participating in today's session, that would be great. So do that. And then finally, third, please come back and see us tomorrow. We're going to start same time as we did today. So we are going to start at noon Eastern time. So that's 12 p.m. Eastern time, 9 a.m. Pacific rather. And we're going to use the same link that we did to be in here. So the second link you received today, go ahead and log in today, or excuse me, tomorrow for that link as well. So it's the CHC Zoom link. So with that, and thank you, Megan, for putting the link for this White Cement Education platform for those CE and CME credits. That's fantabulous. So with that, on behalf of the entire planning team, the advisory group, and all of our partners here today, thank you again for joining us. We look forward to seeing you at noon Eastern time tomorrow. So April Lewis is going to kick off our time together. She's going to be our keynote tomorrow. And so she's going to also be talking about workforce wellness and specifically how to manage your time and energy. So she is wonderful. She is thoughtful. She is engaging. And so I hope you'll join us for that opening session as well as the rest of the day tomorrow. So again, thank you all for joining us. We really appreciate it. We hope you have a wonderful evening and we'll see you tomorrow.